So we're covering main classes of antidepressants. We talked about the MAOIs, big drug interaction there, big issues to worry about with MAOIs. We talked about like tyramine reactions, right? Remember, other drugs that potentiate the effects of like serotonin and norepinephrine will certainly be enhanced when you have monoamine oxidase inhibitors on board. How long does it take for people to kind of wash out from the effects of an MAOI? About 2 weeks or so, right? So again, think about that period too. You don't want to start up on another antidepressant right away because they're still going to have lingering effects from the MAOI, and we'll talk about what can happen when that occurs there. Talked about the TCAs. Any big problems with the TCAs? So you can see arrhythmias because they have like sodium channel blockade effects. Remember, they're like really strong anticholinergics. So would I expect to see diarrhea, constipation with those patients? Constipation, right? Remember, you could use it for bedwetting potentially because it causes urinary retention. Seizures are another big thing you can see with that, especially if the patients are taking too much. So yeah, so again, think about these kind of common sort of side effects, issues with the drugs, because again, ultimately they all are pretty similar in terms of efficacy. So I'm not going to ask you on a test question, you know, which one of these is the most effective antidepressant, because there's not really a good answer for that. But I can say based on this type of patient, which one of these would be inappropriate. So if they're on opioids for chronic pain and they're depressed and they have constipation from the opioids, maybe a TCA is not a good option to start with, right? But for the most part, most patients are going to start with which class? SSRIs, right? Because again, the safety profile is extremely good for those compared to MAOIs and TCAs, right? So very wide therapeutic index from that standpoint. One thing you do want to be cautious with these patients is to make sure they don't go off of them cold turkey, because you do find this discontinuation syndrome. It can lead to some pretty significant nausea, vomiting. They can have rebound anxiety. They feel pretty miserable when they, even if like miss a single dose for some of these meds that have a shorter half-life, because the levels will fall more precipitously. So in some cases there we can actually, if you have a patient who you're worried about compliance issues, you can actually do something that has like an active metabolite, and that actually helps to taper off the dose or the blood levels a little bit more gradually. So for instance, if you had someone who was a compliance issue, an adherence issue, you could consider using, like, for instance, fluoxetine, because that has an active metabolite such that you'll find that the levels, instead of something like, go back to drawing. So instead of say something like, you know, escitalopram, which if they stopped taking it, maybe they would find the levels would drop pretty precipitously. Something like fluoxetine with its active metabolites, you'd find the effects would be more sustained for a longer period of time, and that will help to mitigate some of those withdrawal effects, right? So sometimes you may be making decisions based off something like that. Otherwise, you just have to taper off of their doses, right? Fairly slow, could take weeks, could be a month or two in order to do that for those patients there, okay? For some patients, you're going to find we start them off on SSRI if they had kind of underlying anxiety issues, which again, you know, may have been what's kind of triggering their depression in some cases. You may find that SSRIs could actually worsen anxiety for some patients. For most, it will tend to help, if anything. So I'm just going to be very patient dependent in those cases there. Other kind of unique thing you'll see in terms of effects here with citalopram and escitalopram, just remember those can cause QT prolongation, right? So which maybe opioid would you not want to mix that with? My methadone would be a bad option, right? Because that also prolongs QT, right? So kind of think about these different drug interactions that may pop up. So as I mentioned before, we talked about that increase in suicidality risk, and this is more prominent like in children and adolescents, at least in the short-term studies they were looking at. Again, the full mechanism is not really that well understood, but I kind of think about it in terms of like they get that little bit of energy back, they start to feel better, maybe not better, but they feel like they have more energy to act on some of the sort of negative thoughts that they had, and they end up trying to harm themselves. So it's a risk, and you just have to let patients know, and especially family members know that, hey, this could be something you'd want to watch for, right? And in some patients, like say for instance bipolar disorder, by initiating one of these meds may actually trigger a manic episode. So again, just things to educate about and just let them know these are what you need to be aware of. Up next we have the SNRIs, and so these are going to be mainly working on both serotonin and norepinephrine reuptake transporters. So they're going to block both of those such they should have increased serotonin levels and norepinephrine at the synapse. These are going to be much safer than you would see for the TCAs, because they don't have all those kind of ancillary effects on like muscarinic receptors and alpha receptors and all of that. They're much more specific for just these two transporters here. So in safety comparisons, this would be better than a TCA. Probably not as good as a SSRI because, again, SSRIs are just specific for that serotonin transporter. We've mentioned a few SNRIs before, but you will frequently see them being used for other things like neuropathic pain. Typically, it's that norepinephrine effect that kind of helps out a lot with that. So if he has, like, post-herpetic neuralgias or diabetic neuropathies, fibromyalgia, things like that, typically using an SNRI can be a good agent, especially if they have concomitant depression to manage that. So we have things like venlafaxine and desvenlafaxine. So again, those venlafaxine being the racemic mixture, desvenlafaxine just being the enantiomer. Duloxetine or Cymbalta is probably a pretty common one that I see being used for neuropathic purposes quite frequently. Milnacipran or Savella, I've never really seen all too much, but then we had that levomilnacipran as well. So again, you kind of see the. And why do they come out with these single enantiomers? Like, why do they do that? Why? Jeez, you guys are so jaded already, and haven't even gone on clinicals yet, man. What could be maybe a more altruistic reason? Maybe it's more effective. Maybe you just get the one enantiomer that's effective. What else? Or could, yeah, so maybe you're getting rid of the enantiomer that has the side effects associated with it, right? So again, you may see there's some differences in terms of side effect profiles potentially, but just be aware that's not always going to be the case. Sometimes they just want a new patent and they get another 20 years on this medication. They're like, well, look at all the safety data with the racemic mixture. We don't have to go through as many clinical trials or as much data to show that this is also going to be effective. Here you go, right? So just something to consider. Getting into the adverse effects here, you typically will see probably a little bit more side effects from an SNRI than you would just an SSRI, typically because you have those extra norepinephrine effects. So for instance, which one do you think would be more likely to trigger anxiety in a patient, SSRI or SNRI? SNRI, because again, that norepinephrine is typically pretty stimulating, right? It's part of that sympathetic nervous system. Again, you can still find sexual dysfunction in these patients. It's going to be ubiquitous amongst all of these different classes as we've seen so far. Duloxetine has a little bit of anticholinergic effect, so again, you may still see some of those things a little bit like a TCA, but pretty light in comparison to an actual like full-blown TCA there. And again, because of that norepinephrine effect, you can also see rises in blood pressure too, because it will have some extra triggering of those alpha receptors. So you would want to be cautious if you had a patient who maybe had like uncontrolled hypertension. It would be kind of a relative contraindication. You want to be cautious with that type of patient. We have a couple of mixed agents here. So we have something like trazodone and nifazodone. Trazodone is probably more common that I see than nifazodone. Nifazodone has some issues with causing some liver dysfunction, so I don't see that one as commonly. But basically, it works as both a serotonin reuptake inhibitor, and it also works on this 5-HT2 receptor. It's actually an antagonist there. Clinically, what that does for us, not necessarily a whole lot from a depression standpoint, but this also has some other ancillary effects. So for instance, like trazodone also can block alpha-1 receptors, which means that can actually lower blood pressure or lead to things like postural hypotension. If I have patients who have overdosed on trazodone, typically they're pretty sleepy. Like these tend to be very sedating for the most part, and also their blood pressure is usually an issue. Either we have to give them pretty aggressive IV fluids, or we might even have to start up some light pressors like norepinephrine or epinephrine for those patients there to try to overcome that effect. Also, kind of a unique thing with trazodone is its tendency to cause priapism. So again, if you have like a, I don't know if it would come up on the boards or not, but this is kind of a very unique sort of side effect you at least want to be aware of. And I have seen that a few times in overdose for some of these patients here, but it can happen with just therapeutic dosing as well, so you would want to be cautious with that. So frequently though, and again, this is before PAs and NPs could write for controlled substances, because a lot of our sleep agents typically kind of are similar to benzos in terms of their mechanism, and they're all controlled substances. So before you guys could prescribe controlled substances, frequently I'd see trazodone being used for sleep, and so that's a pretty common thing you may find out there. Be cautious though, if you have a patient who's also on an SSRI, you may not want to use these two together, because we're going to see there's a risk for serotonergic toxicity, as we'll talk about in just a little bit, okay? Especially if you mix these with other medications that cause sedation, like opiates, alcohol, things like that, they can tend to be pretty synergistic, so you want to be cautious with that. So next we have bupropion. We've actually talked about this one before. Anyone remember where we talked about this? For smoking cessation, right? So the novel mechanism with Wellbutrin, and over there, anyone remember the brand name for smoking cessation? Chantix was actually varenicline. It's actually Zyban, I think, was the brand name there. So again, another way to get a brand name drug. Though, look, we're using this other indication now, so now we can make more money off of this. again, you're probably jaded because I made you jaded, so I'll own that one. Anyway, but Wellbutrin works because it's kind of novel. It doesn't really work on serotonin so much, but norepinephrine, and then also affects dopamine, which is why you'll see it used for things like overeating disorder, smoking addiction, things like that, because it's able to kind of help kind of re-regulate that dopamine pathway, that reward pathway that is linked to addiction. And so that's why you're starting to see that being used for some of those purposes there. In terms of, look at the brand name on the slide already. So I already knew it was Zyban. Even look at it. So steel trap up here. Got a lot of holes in it, but it's still steel. Anywho, though, so you'll see this used for different purposes, but again, if they have concomitant depression, anxiety, this may be somewhat useful there. In terms of side effects, so if I was talking about like dangerous meds to overdose on, and again, why do I keep mentioning overdose for these drugs? They're depressed, right? So again, they're at higher risk for suicide. So this is why we end up, or at least suicidal tendencies and actions. And so this is why I keep mentioning this, because this is a very frequent thing you're going to find. If you're working in an ER and a patient overdoses on several substances, it could be quite frequently that antidepressants are going to be in the mix here. This one is really quite dangerous, as you'll find an overdose, and this one can actually be sort of a. Did my mic go out? Kind of going in and out. All right. But basically, it can kind of be a little bit of a sleeper, so to speak, in terms of its toxicity. I've had cases where patients will look fine, and then we go to like send them up to the ICU. They go in the elevator, and they come back out, and they're basically like coding the patient because they went into like a ventricular arrhythmia. Like, it can be pretty significant in terms of causing arrhythmias, and then also seizures can be another big risk with this one as well. So, and again, some of it may be related to that norepinephrine sort of effect. The cardiac effects, not quite sure in the mechanism, but that tends to be something that we end up seeing as being a risk there. Because of that norepinephrine effect, you will see some agitation in some patients. Anxiety may be worse in here. So probably not the first thing I would use for a patient with anxiety, but the other claim to fame for bupropion, though, is it has the least amount of sexual dysfunction out of any of the antidepressant classes we've talked about so far. So frequently, if a patient is complaining about that, either they just don't want to have sex anymore, or they just cannot perform well, then they can consider switching over to bupropion. They typically will have better results with that. But if they have like a seizure disorder, if they have a history of arrhythmia, I would probably avoid using that in that case there, right? A couple other atypical sort of agents here. We have like mirtazapine or Remeron. This one actually is working on some of these alpha-2 autoreceptors, helping to regulate those. Those can also affect some, they work to kind of increase norepinephrine and serotonin levels a little bit. This is going to be more sort of like second or third line. If a patient has maybe failed an SSRI, maybe they failed an SNRI, so maybe something you want to consider using there. But it has a lot of mixed actions here. And so because of its antihistamine actions, you end up seeing a lot of somnolence with this, weight gain, dry mouth, constipation. So a little bit more problematic from a side effect profile, which is why it's not going to be one of those first line agents. Vortioxetine is a relatively new agent. Here we're going to find it also works as an SSRI, but it affects a lot of different types of serotonin receptors. And I mentioned, in terms of serotonin, it has all kinds of varieties of receptor types. So for instance, like Zofran blocks which serotonin receptor? 3, yeah, very good. What does, say, for instance, like your triptans work on? 1B and 1D, right? So there's a huge number of subtypes, as you'll find. And so here you're going to see that it works on like a 1A, a 7, a 1D, a 1B. Don't memorize that necessarily. Just know it has a lot of mixed actions in terms of its effects on serotonin receptors. Here you're going to find that in terms of like adverse reactions, again, this is not going to be like a first line one, again, maybe second, third line potentially. They have a lot of sexual dysfunction associated with this one as well. Nausea, diarrhea, pretty common with this one. And then you have to be careful. If they are a poor metabolizer, CYP2D6, they're not going to be able to clear it as well, unless they can cause some accumulation and some risk for serotonin toxicity. So that leads me into serotonin syndrome. And sort of like before you get all the way to full-blown serotonin syndrome, there's what we call serotonergic toxicity. That's kind of what I've been mentioning so far. What is serotonin syndrome? You think you have all the serotonin, you'd be like super happy, and you're just like hugging everybody, and no, not really. Basically, this is typically seen if you have multiple medications that are all potentiating the effects of serotonin. So, for instance, if I had a patient on say, phenelzine, MAOI, and they were to come off of that, and I immediately switch them over to, say, escitalopram. Because they haven't had that 2-week washout period, you would end up seeing that they'd have too much serotonin because of, one, I'm blocking the reuptake with the SSRI, but I'm also inhibiting the breakdown of that serotonin through the MAOI. you can end up seeing way too much serotonin effects here. And so this is kind of what happens with these patients. There's kind of four main things you're going to see here. One, they're going to have some degree of altered mental status. They will have hyperthermia typically, so they get pretty hot. They will have autonomic instability, which means they may be hypertensive and bradycardic, or they may be tachycardic and hypotensive, but usually their vital signs are going to be somewhat out of range. And then they typically have this increase in muscle tone. You see this more in the lower extremities. They'll have this inducible clonus. That is pretty typical for serotonin syndrome. This is kind of a diagnosis of exclusion. So if you have a patient, they have a history of being on an SSRI, they kind of present like this, but what could these other things kind of look like? So they're hyperthermic, they are acting wacky, vital signs are all, maybe they're hypotensive. It could be like meningitis or something, right? Or it could be sepsis, or it could be lots of different things. You want to rule out all that other stuff first, all the other medical things, and say, okay, well, I've kind of ruled out everything else. Here's kind of the smoking gun with the medication. This is why I think it's going to be serotonin syndrome. And so frequently, especially like when I have patients who have overdosed on multiple medications, there's frequently several reasons why they may be experiencing some of these things, and I can't necessarily attribute it just to that SSRI. So you got to really exclude everything else. I had one really interesting case that happened. I actually got a call about this from a surgery center. And so one of the things that they'll do sometimes in surgeries, they'll use certain dyes in order to have it accumulate in certain organs in order to help with excision, right? So I think for this one, they're using methylene blue, which I mentioned before, used for hemoglobinemia. It also tends to accumulate in the parathyroids. And so this guy was doing surgery, and if you recall, talking about methylene blue, actually has some monoamine oxidase inhibiting capabilities, and they did not screen the patient appropriately and realized that when using this methylene blue, it might interact with their SSRI. So they're in the middle of surgery, trying to take out this patient's parathyroids, and then all of a sudden, they start to get really hypertensive, all of a sudden their temperature's going up, and they're like, what the heck's going on here, right? Of course, they can't tell if the patient's altered because they are under general anesthesia. And so it's a very kind of interesting thing where, looking for those drug interactions and screening for that stuff is really, really important in those cases. Anyway, so just be aware of if you see like an MAOI on board and they have that tyramine reaction, this is a risk for that as well. Or if you're using multiple serotonergic medications, this is going to be a risk. Okay, have you heard of NMS before? Neuroleptic malignant syndrome. We're going to talk about that a little bit later with the antipsychotics. This looks very similar, but we'll talk about some differences, and it can be difficult to determine which one the patient's experiencing. So again, they may be sweating, may be hyperthermic. It doesn't have to be full-blown serotonin syndrome. They could just be experiencing some of the toxicities. Say, for instance, if they ended up taking 2 SSRIs together, or maybe they're taking SSRI and they took an SNRI on top of that potentially. Basically, what we need to do for these patients is basically aggressive IV hydration. Make sure you keep the temperature under control, right? And again, is something like acetaminophen necessarily going to be all that effective? Not really, because the issue is of the actual medications causing these aberrations in serotonin. Tylenol is not going to do anything. So we may use like cooled IV fluids, may use evaporative cooling, may mist down the patient and put a fan on them, and that can help. So cool them down, hydrate them, and then we can actually use an old school antihistamine called cyproheptadine. It actually has some anti-serotonergic effects, and so we can actually use that as an anti-serotonin drug to try to block some of that effect, kind of mitigate it a little bit. So that's something you may see occasionally there. And again, what do you think they get rhabdo from this? If their muscles are all tensed up because they have all this clonus, that can lead to muscle breakdown. It's not super common. You see that a lot more with NMS. We'll talk about that later on, but it could be a potential issue there, right? If they started seizing, what would you give them? There's some benzo. Yeah, lorazepam is probably the one I would probably go with, assuming we have IV access there. If I did, maybe some intranasal midazolam or something. But yeah, for any drug-induced seizures, just go with benzos all the way. Usually a lot of other anti-epileptic drugs aren't all that effective, but benzos, maybe a barbiturate, but usually benzos work. Okay, so as I mentioned, in terms of the kinetics there, this is an important thing to consider. We already talked about like fluoxetine, for instance, having those active metabolites, having a nice kind of taper effect, such that you don't have the withdrawal syndrome that may show up with something that may have a shorter half-life, right? So that's one thing to consider. However, you may want to give the patient a little extra time. Say they were on fluoxetine, but they couldn't really tolerate it, and you want to switch them over to something else. That wouldn't be one you want to switch over from day 1 to day 2. Go from fluoxetine, say, to citalopram, because again, they'll have some of that residual active metabolite left around that they could see against some serotonergic toxicity. So you may want to give them some extra time to deal with that. Okay, a lot of these drugs are going to be metabolized to the liver, so if they have liver dysfunction, you do want to watch out for that because it could have extended half-lives. It could be several times normal in like a fully cirrhotic patient, so again, you got to be cautious. We don't really do any therapeutic monitoring for these drugs because there's no real good correlation between like the level of fluoxetine in the body and the actual therapeutic effect we get. Most of it's just going to be based off of patient response, right? So again, how do they feel? How, what are their scores at on these various scales and things you're learning with Dr. Austin, different things like that. But again, it may take up to 6 weeks before they really see full effects. So you have to let them know that even though side effects may pop up early, full efficacy may take a while. Yeah. So, as I mentioned, in terms of drug interactions, you see a lot fewer of those. Most of these are going to be more pharmacodynamic reactions in terms of the drug's mechanisms interacting with one another. Fewer PK interactions, like pharmacokinetic interactions with some of the newer agents, which kind of helps out with the safety profile. Not a lot of issues with like your SNRIs or bupropion, for instance. Again, basically the takeaway, I'm not going to get into and tell you every single CYP interaction that can happen because it's variable depending on the SSRI you're talking about. But again, what are you going to do before you may like prescribe one of these to a patient? Just look it up. Just do there's plenty of interaction checkers out there. You just type in all their meds, and then you go right. And again, they may be on a lot of meds, maybe a lot of interactions that pop up. But again, you want to look for the really kind of the ones that show up in red or orange. Those are usually the ones you want to look at, right? It's usually pretty consistent colors. If you have color blindness, I don't know what to tell you. If it says X maybe, that's not a good one either. Okay. I'm just trying to be inclusive. You're welcome. Anyway, you'll see that TCAs tend to be pretty extensively metabolized through the CYP enzymes. 2D6 tends to be a pretty big one there. If you have any interactions that are there, you may not necessarily be contraindicated from starting one of these meds, but again, start low and go slow and see how they're going to tolerate it. Most of the time, these patients are going to stop one of these meds because of the side effect profile, so that's what you really got to be worried about in terms of that. It's not necessarily the overall efficacy. And even sometimes we have issues of protein binding interactions where TCAs tend to be pretty highly bound to things like albumin. Something else comes and kicks it off. That free fraction goes up and all of a sudden it's much more active, right? So, and as I mentioned, anything affecting serotonin, norepinephrine metabolism, all of that can end up leading to that serotonergic toxicity and serotonin syndrome particularly. So for instance, like I said, linazol is probably the one you'll run into most clinically because it has some MAOI activity. But say for instance, I have a patient who develops, say, MRSA pneumonia, I'm thinking it's MRSA. I put them up in the ICU, you say continue all their home meds, includes something like, say citalopram. Cultures come back and it says, nope, it's VRSA. I want to switch them over to linazolid. What do you do about that SSRI? Do you continue it? Do you stop it? That could be a case where if the patient's sick enough, they can probably stop the SSRI, right? You can kind of manage around that, kind of treat them symptomatically. However, remember that, it may take a while for that drug to wash out of the system, especially if it's been dosed chronically and they kind of built up some tissue stores. So in some cases, you may just have to work through the serotonergic toxicity. You may know they're at risk. You want to be cautious with it. You may want to be aware of it. But, am I going to wait, say a week for drug to wash out before I start linazolid if they have VRSA? Well, no, you got to treat the VRSA, right? So little things you have to consider depending on the situation. Like I mentioned, methylene blue is an interaction not a lot of people think about. Triptans can be one that will interact here. So if they have depression and they have, say, migraine disorder, you can see some additional effects on that serotonin receptors because, again, they're 1D and 1B agonists. So maybe you see increases in blood pressure higher than what you would normally expect. Little things like that you want to consider. And typically they're going to require, if you can, maybe a 2 to 5 week period where they're going to be slowly tapering off of their other antidepressant before you start up a new one. That's the ideal, may not always be feasible. Okay, as I mentioned, in terms of QT prolongation, which two SSRIs did I mention are big for causing that? So citalopram, and then by association, escitalopram will do that too. We'll talk about several antipsychotic agents that are going to come up here in a little bit that are also going to do that. So that's another consideration. You may want to check an EKG before mixing those drugs together and then see how they respond afterwards. Now, is it common that patients with depression get put on an antipsychotic? Maybe not common, but you can actually, some of them actually have indications for treatment-resistant depression. So you may find some of them will have an add-on of an antipsychotic, even if they don't have a history of schizophrenia. So that's kind of one of those things you'll find for some of these patients here. Okay. Antiarrhythmic surely on a potential interaction as well. Yes, sir.
So is there like bridge therapy for this, or they just kind of have to stick with it until like these medications start working too?
Yeah, it depends on the situation. So in terms of like acute depression symptoms, yeah, you can't really do a whole lot with that necessarily. Sometimes they're in a place where they can get that additional help. So for instance, if like, say it's like a new onset depression and they try to kill themselves and then they get cleared from the ER eventually and get moved over to a psych hospital. Like that could be a good period where they can start up something and they would at least be monitored and they'd be talking to people and they can help them out. From the anxiety standpoint, sometimes we'll talk about generalized anxiety a little bit later on in the meds we use there. Sometimes we can give some additional help in terms of things that can work for acute, anxiety symptoms. We'll talk about that later. That's a good question. And again, mixing these with alcohol tends to be not great because again, you can see some synergistic sedation effects. So be cautious with that. Do depressed people ever drink? Yeah, it's a pretty fairly common thing. So you want to be cautious there. Okay, so St. John's wort. I've never had a wart so fantastic that's gotten like named after a person, but this one must have been pretty interesting. But anyway, this is an herbal supplement you may find that has some efficacy for mild depression. Now, am I one of those people that says herbal supplements don't work? Yes. No, I'm not one of those people. Why would I ever give you that inclination to say that? No. They can be pretty effective for some things, right? What are the caveats with that, though? Yeah, they're not FDA regulated. You can't necessarily say that what's on that label is specifically what's in that bottle, right? So again, sometimes you get what you pay for. It's good to go with reputable brands. Just make sure patients know that, not to go like get the guy selling stuff out of his trunk outside of the GNC or something. May not be the best person to buy from. I used to be that person, so I know. I'm just kidding. So interestingly enough, this plant has several active compounds in it. So for instance, like hypericin has MAOI action, right? So it actually works just like any other MAOI would. It also has some reuptake inhibition of monoamines. They actually work as almost like an SSRI as well. So again, it does work for some mild cases of depression, but you need to make sure that patients are at least being honest with you and letting you know if they want to try it, you can, great, but what would happen if I mix this with like an SSRI? Same serotonin risk I would see if I mix this with any other antidepressant drug, right? So again, you have to make sure that if they want to try it or if they've maybe on it already because they say, oh, it really worked for someone else, I'm going to try something natural, blah, blah, blah. That is something that you need to know about. The other really big thing you have to be cautious with St. John's wort is the several drug interactions that can happen here. So this is actually a CYP3A4 and a P-glycoprotein inducer, so it actually will help to raise or lower levels of drugs that are affected by those two. Lower levels, right? So for instance, other drugs may be less effective because they're getting metabolized more quickly. And again, this is why when you're doing your med history, you have to ask about herbal supplements they may be taking or things they get without a prescription. So again, those are the risks. Certainly could be effective by itself, may not be for more severe cases. That's where pharmacologic therapy is going to be maybe a little bit more helpful. Yes, ma'am. It's probably not a bad idea. Sometimes what you can see is you'll start a taper off of one and then you can start at a low dose of the other, maybe after like a week or so, and then start to titrate up on that. That helps to provide a little bit more kind of better continuity and exposure to drugs without causing too much toxicity. They could, yeah. So for instance, if they're on oral contraceptives, like estrogen-containing ones, that could increase the metabolism thereof, lower the levels, and then ovulation could occur, right? So it is a thing to consider, certainly. And again, if you're not sure, those interaction checkers will also cover a lot of those common herbal supplements as well, so you can screen for that additionally. And again, herbals definitely do work. I had one patient who had come in, I've probably shared this story before, but she was an elderly lady. She was on warfarin for her AFib, and then, elderly people, their memory starts to go a little bit. What herbal supplement can help out with memory? Ginkgo. And really, one of the caveats I learned when I had to take an herbal class in pharmacy school was that anything that starts with a G typically has some antiplatelet or antithrombotic effects. And so she started taking some ginkgo along with that warfarin, she didn't ask anyone to start the ginkgo, she just did it on her own, right? Because she can do that. Ended up coming like a massive head bleed, right? Because again, they were very synergistic with one another. So you do have to be cautious. The herbal supplements certainly can work. They can also cause some toxicities. They can be quite dangerous if not screened appropriately. So you never want to just entirely poo-poo the idea with your patients. If they are interested in it, at least explore it. At least edify yourself a little bit into the risk and the potential benefits from it, right? So anyway, typically you're going to see in the elderly population, this is frequently overlooked. So depression is definitely underdiagnosed in this patient population, as in most populations. But the big things here is you have to really make sure you do that thorough medication history to look for any drug interactions, either from a kinetic or a dynamic standpoint, to make sure you kind of look out for that. And again, especially like with elderly patients, anything you're going to start off that's going to be a sedative can be problematic, because again, is grandma getting worse in dementia, or is it because she started up on a TCA that sedation starting to kind of cause her to be mad as a hatter, so to speak? Those are things you want to be cautious with, right? And again, they just have less physiologic reserve, so things like, say, for instance, trazodone, right? I'd be really worried about postural hypotension in, say, an elderly patient. So little things to screen for. In terms of pediatrics, this is probably a lot more prevalent than what we originally thought, and we don't have a ton of studies, right? Because again, doing pediatric studies is difficult. So a lot of what we're doing is taking information from adults and just back extrapolating that. And as you know, children are just little adults, right? No, based off the lecture we just had, it is not. They do, fluoxetine at least is one that does have an indication there, so you may see some patients start out on that. But again, in those short-term studies, that increased suicidality risk is there, so you do want to be watchful for that, right? At least make sure you educate the patient and the caregivers as well. Okay, we'll talk about this topic of pregnancy-related depression and postpartum depression more so in the OB-GYN section. This is definitely something you will see a lot of, especially if you work in OB-GYN. We typically will find that you have to weigh the risk versus the benefits, because ideally, what's the right amount of drug exposure for a fetus? Be 0 would be ideal, right? But if mom's at risk for major depression, potentially suicidality, that would be something where the risk of exposure of an SSRI to a fetus may be outweighed by the benefits of giving it to the mom, right? So you're starting to see more SSRI exposure to the mother during pregnancy and after pregnancy. So there may be some small risk associated with that, things like, I think, pulmonary hypertension, I think, has like a slight increase in risk, and there's a couple other little things, but nothing such that the kids are going to come out like a neural tube defect, nothing severe like that, at least has been shown consistently. What's interesting though is we talked about the serotonin discontinuation syndrome from an SSRI. You can actually have fetuses that will do the same thing. So just like I mentioned with neonatal abstinence syndrome, NAS, you can see if like a baby's withdrawing from opioids because a mom is using during pregnancy, you can actually see the same thing in fetuses of moms that were being exposed to SSRIs. And so we actually got a call one time to the NICU. This kid was just like not acting right. The kid was just not feeding well and not really able to regulate their temperature very well. And then we were looking at the history, and like the mom had been tested for urine drug screen. She was negative for everything. Got the med history, and then found she was taking fluoxetine throughout the entire pregnancy. Kid comes out, and all of a sudden is in the NICU, not getting breastfed, and was basically being deprived of that medication. All of a sudden, they has serotonin withdrawal just like anyone else would. So again, little interesting things to kind of consider. So, as I mentioned, typically you're going to start off with an SSRI, maybe a newer agent if you have a compelling indication. So if they had, say, a history of neuropathy or neuropathic pain, maybe an SNRI might be a good option there, right? Or if they have a history of hypertension, maybe not an SNRI. Typically TCOAs, reading too fast. TCAs, not going to be recommended as first line. Typically, you're going to hold back on that if they failed some of these other options, right? So if they failed SSRI, SNRI, try switching over to a TCA potentially. Remember, a lot of side effects, sedation probably being the most common one you're going to run into. MAOIs are going to be typically the last resort. I don't know that I've ever seen anyone actually on one. And you're like, well, why are you teaching it to us, right? But again, the concept I think is really important too, right? Because we covered it in Parkinson's. I've certainly seen patients on selegiline before. Linazolid, you're going to use that if you work, anywhere you're treating infectious disease potentially. So it's good to know the concept, right? Know the underlying issues. And I get to talk about the bougie food, so something that'll probably stick in your mind if I had to guess. So if they fail therapy, again, you have to assess compliance. And again, we don't have good readily available assays to do levels, so it's hard to say, okay, well, I don't have a level necessary to point to say, yes, you were taking it. And again, patients may not be honest with you if you ask if they're taking it like they're supposed to. So that can pose some challenges there. You will find that just because they fail, say, a drug within the SSRI class doesn't mean they're going to fail all SSRIs, okay? Patients are going to respond very differently between these. You may find that, citalopram, they had decreased libido and they just felt even worse on it. You can try switching them over to something like fluoxetine or sertraline. Any of those would be totally reasonable there, right? Just make sure you give them a little bit of a washout period. You start to wean them down off of the dose of whatever they're on currently, and then titrate up on the new agent there to make sure you don't have any issues, okay? As I mentioned, you may have to add on additional agents depending on comorbidities, like if they have bipolar disorder or if they have really treatment-resistant depression. You may add on something like an antipsychotic. Aripiprazole or Abilify is a pretty common one, and we'll get more into that in just a little bit. Any questions on that section? At all? Yes, sir.
When you say washout period, even the same exact theory mechanism requires a washout?
Yeah, because if I have, say for instance, you were taking fluoxetine for 6 weeks, that one in particular, because it has an active metabolite, right? So let's say not even that one. Let's say, citalopram. Say you've been at steady state for a couple of weeks now. You still have body tissue stores of that stuff. So if I were to say switch them over from that over to, say, sertraline, they still have all that citalopram that's in the system now on top of that sertraline, okay? So it's still that risk there for sure. You want to be cautious. Okay, you guys are asking a lot of questions. I like that. It's great. Shows you're engaged. Maybe the 8 o'clock classes and the 2:30 class is the problem. It's when you're trying to get out of here, and the other one you're not awake. You have to actually ask questions in the first place. So interesting. The 10 o'clock spot is a sweet spot for engagement. Okay, so getting into bipolar disorder. So what is bipolar disorder? They go from up and down, right? So, and I kind of think about like SSRIs, like a patient with like depression, they have really low lows, right? And I kind of think about SSRIs as kind of shaving off the peaks and valleys a little bit, such that they don't get as low lows. They also kind of don't get as high highs. You'll find that they may have sort of a depressed affect sometimes, especially if they're on a little bit too high of a dose of an SSRI. But with bipolar disorder, certainly they have the really high peaks there as well. You do want to be able to manage that, right? So we have a whole set of drugs that are going to be used called mood stabilizers that will help us to kind of regulate that and make sure that they don't have those really severe manic episodes. Because what can happen during these manic episodes? Like what kind of dangerous things? Like I cleaned my house and it looks great.
Yeah, it's the worst.
Buying a lot of stuff, all of a sudden your Amazon order's going crazy and you have all kinds of things showing up at your house. Driving fast, reckless decisions, right? Maybe I have bipolar disorder. Driving fast is it. What other things? Gambling could be. They have this kind of compulsive gambling kind of thing that can occur there. Infidelity, risky sexual behaviors is another big one you'll see there. So a lot of things, right? And again, it's not just full-blown mania that we're necessarily worried about, but like the hypomanic episodes can be a thing too. And sometimes the patients don't want any therapy for that because they feel pretty good, right? If I had extra energy, I got my house clean, did all my homework, graded all my stuff, everything looks good, right? But again, you'll see that there's some degrees of gray there. I'm sure as Dr. Austin has gone over. Typically for these patients, it's really important to get started early because oftentimes as they kind of get more progressive, they may not be able to keep a job very well. They may be less adherent to medications. It can be a challenge with these patients because a lot of times they don't think they need anything because they feel pretty good for the most part when they're in the more manic phases. So certainly most of these patients will end up on lifelong pharmacologic therapy in a lot of cases there. We don't really know why this occurs. Again, it'd be nice if we could figure some of the stuff out. Maybe we could get more targeted therapies, but for the most part, we know that our medications work. We just don't really have a good full mechanism for that. So I'm not going to get all the way into the different varieties thereof, but just know that a lot of the medications we're using here are to try to manage more of the manic episodes or try to prevent them from occurring. You still need to consider something for the depression side of things. So you will typically see these patients may be on an antidepressant like an SSRI plus, say, a mood stabilizer to help with the more manic aspects of it, right? So there's not really one drug that kind of works for both in those instances there. And again, there could be other causes for this, right? So for instance, if you had a patient who was taking cocaine, for instance. They may appear to be in a manic episode. They really feel, you guys seen Wolf of Wall Street? Those guys seemed a little manic, right? But it was just oodles and oodles of cocaine coursing through their system, causing those sorts of things. But certainly, alcohol withdrawal can appear like this, right? Alcohol is typically a depressant. You remove that, they have the kind of a rebound excitation that can occur there. Again, withdrawal seizures is a possibility. Hallucinogens, like when we had bath salts and things like that, when those are first kind of coming out on the scene. When I was in training, I mean, it was really fascinating to see just the weird presentations for these patients show up with this like very manic flight of thoughts. They couldn't keep anything straight. They'd go on to 3 different topics within the span of 30 seconds, and it was just wild to watch, right? And it'd be for a couple of days just from exposure to these bath salts. So a lot of different things that could be causative here that you want to rule out before you say, yeah, it's going to be definitely bipolar disorder. So our goals, you'll find here that we will have management for both acute episodes, because a lot of times these patients will get sent over to the ER because they may be a danger to themselves or others potentially. So we'll talk about some ways to kind of help get that under control in the acute phase. And then we'll talk about sort of maintenance of symptoms and try to keep them sort of at their baseline, hopefully. So we'll look at some ways we can do that. As we mentioned, risky behaviors is pretty common for these patients as well. So typically they may have a component of a manic disorder, plus on top of that maybe they're using amphetamines or using cocaine or something like that. So you really want to look at the substance abuse issues as well and try to help get that under control and try to avoid any like substances or stressors that may be inducing that, right? And so therapy is going to be pretty individualized based on the patient, seeing kind of what they respond well to, what kind of side effects they're going to experience here. There's not going to be one drug that's going to be the absolute best for every single patient you're going to run into. So we'll look at some different options that are there. Typically, though, they're going to want to stay on that mood stabilizer, but is compliance an issue for these patients? Yes, just like I mentioned, this can be tough, but we'll look at some options that are going to be there. Obviously, you want to focus on the non-pharm stuff as well, so make sure they're getting good nutrition, good sleep, maybe some exercise, some stress reduction. All those things can just generally help out a patient's overall well-being. Doing things like keeping a diary and mood charting can be helpful as well to kind of identify anything that may be triggering their symptoms there. Let's talk about the drugs. Lithium is one that is a little bit more old school. It's been around for, since Earth was Earth, just a metal, right? And so actually it used to be contained in 7-Up. So actually you could lift your spirits a little bit by affecting your mood. I would still think cocaine has kind of the best additives to it, or not cocaine, Coca-Cola I should say, has a history of the best additives to it. I mean, isn't that wild? Like, legit had cocaine in it. It's insane. But looking at this, we'll see that lithium is effective at what it does, but a whole host of problems in terms of side effect profile, in terms of drug interactions, but it still can be used somewhat commonly for patients who maybe have failed other therapies. And this used to be the gold standard. It used to be just to go to for the majority of patients with bipolar disorder. Now so it's going to be less likely, as you'll see. One thing to kind of think about in terms of lithium is that if you look at it on the periodic table, I'm looking at it right now because I have the whole thing memorized. Just kidding, I don't. It's actually pretty close to sodium on the periodic table. They're kind of neighbors. And so to think about it that way, sodium and lithium kind of act the same way in the body. And so we'll talk about that, how that can affect the kinetics of it a little bit later. So if you had to guess, is this going to be hepatically metabolized or is it going to get eliminated through the kidneys? Through the kidneys, right? It's just lithium. There's no metabolism to happen to it, right? It's just that metal. So that will get entirely eliminated through the kidneys. So you already can see that if the patient has renal dysfunction, that can directly affect how they're going to be clearing that lithium. So you can already see some issues there. So you can still see it being used first line for some patients, but again, I'm starting to see more and more patients utilize some other mood stabilizers, which we'll get into. The other big thing here as well is that you do have to do therapeutic drug monitoring. It's a fairly narrow therapeutic index, and so even if you look at the units here, notice how it's milliequivalents per liter, just like you would look at like serum sodiums and things like that, so it's kind of indicative of that. But fairly narrow, right? So 0.5 to 1.2 is considered sort of a therapeutic level. If a patient gets up to like 2.5 or 3 even, that's where we have to start considering things like dialysis in terms of patients that have to get that drug eliminated because it's so likely to cause a lot of CNS toxicity. So I had a call probably a couple of months ago. It was like a freestanding ER, how there's like popping up everywhere, kind of like CVS and Walgreens, practically. and I had a call, and they said, "Oh, we got this patient who took all this lithium," and I said, "Well, what's the level?" And they said, "Oh, it's a send out." And I was like, "What do you mean it's a send out?" And they're like, "Yeah, that's send over to the actual big hospital to get the level done. We don't even know what their level is." And I was like, "They need to go to the actual hospital, the actual ER, like right now, because they're not going to be managed very well, because this is like a potentially really dangerous drug. If the levels are too high, seizures can be really, really difficult to manage here." So little things to consider, because again, these patients may end up taking too much of it, because again, they could be depressed in one of those phases and taking all their medications, and it's not uncommon to see a lithium overdose like that. Anyway, you can see that you don't want to abruptly discontinue lithium as well, because you could see rebound symptoms. You want to be cautious with that. And in some cases, you may have to actually mix and match your mood stabilizers and end up using more than one. So that's a possibility, but again, not the most ideal situation. So a lot of patients will have adverse effects here. Typically, these tend to be related, sort of like peak dose effects. So usually an hour or two after they take it is when you're going to end up experiencing this most likely. Because it is, an osmotically active particle, you can see some GI issues. So for instance, like diarrhea can be quite common with this, because it's just, again, drawing some extra water into the colon there. But typically you're going to find as well that you can cause things like polydipsia and nocturia. What do you think that is? Because again, it looks a lot like sodium to the body. The body can't tell the difference between sodium and lithium. So if it notices there's a big salt load, it's going to try to get rid of that. It may induce urination, or it could actually induce some thirst responses, right, through ADH. So it could be trying to regulate that, because the body's just not smart enough to tell the difference. They look very similar. Other things you're going to find, especially more chronic, and so again, it takes a while for it to kind of build up levels in the system, but once it's there, it likes to stick around for a while. And so you can see things like this fine hand tremor that can happen about up to 50% of patients. So again, it's quite common. You're going to run into that. In some cases, we've actually found that beta blockers can help to mitigate that by actually blocking some of those beta receptors on the skeletal muscle. That can be somewhat helpful. And then, interestingly enough, this can actually cause a nephrogenic diabetes insipidus. What's diabetes insipidus? A lot, right? So this is one of those cases where actually, instead of, because normally you would find that it could be an issue of, like, say, the central diabetes insipidus is related to maybe not sending out enough, like ADH, for instance. Here, this is actually making the kidneys less responsive to ADH. So it's basically just, you're not getting those aquaporin channels in there, just kind of eliminating all that extra urine. So anyway, so that would be one thing. We can actually treat this with a loop or a thiazide diuretic. Like, wait a second. They're peeing too much. Why would I give them a diuretic? So it has to do with kind of re-regulating how they're going to be holding on to sodium and things like that. Basically, by getting rid of some of that extra sodium, things like loop diuretics, how they will help block the reuptake of sodium in the loop of Henle, right? By getting rid of the extra sodium, it kind of triggers that macula density to say, hey, wait a second, we need some more sodium here, we need some more fluid, and so it'll actually help to re-regulate that. It'll actually help to get more ADH being secreted out, and it'll help to re-regulate that way you hold on to more of that urine there. So it seems counterintuitive, but ultimately that's what we end up doing with those patients. Ideally, though, if you knew it was lithium that was causing the diabetes insipidus, the first step would be to stop taking the lithium, right? So again, that's always going to be the first thing you want to watch out for. This can cause nephrotoxicity, and then it actually can induce hypothyroidism. So you do want to watch out for that. The lithium itself can actually interfere with the actual production of hormone, thyroid hormone. And again, what can hypothyroidism kind of look like? Kind of look like depression, right? So again, is it just worsened depression patients may be experiencing while they're on the lithium, or could it be related to their TSH and T3 and T4 and all that? So chronically, you can also see some issues in terms of some cardiac effects. Things like AV block and bradycardia may occur chronically. They can also end up developing some acne is one thing I typically see in these chronic patients who have been on it for a while. But dermatitis, things like that are also a possibility. Weight gain, and if levels are too high, that's when they end up developing more ataxia and slurred speech and whatnot. I'm not going to get too much into the overdose aspect of it, but needless to say, if you had to consider, I haven't mentioned this before, in a while, but the sphincter tone, right? So when I hear about an overdose, like where that's set at, a lithium is probably like an 8 or a 9. Well, it depends, right? If it's an acute one, maybe like a 6 or 7, depending on how big of an ingestion it was. If it's a chronic one where the brain already has kind of levels built up, it's probably like an 8 or a 9. What do you think a TCA is? Based on what I was saying yesterday. That one's like an 11, especially like in the first 6 hours. That one can be really, really bad. So that one we do want to be cautious with. But Let me just finish up lithium. I'll let you guys go on a break. In terms of interactions, anything that's going to affect sodium handling in the body will affect how we handle lithium as well. So, for instance, if I'm dehydrated, obviously the kidneys aren't going to be as perfused as well. You're going to hold on to more lithium, right? If I put the patient on a sodium restricted diet and the kidneys are trying to hold on to more sodium, they're going to hold on to more lithium, as it turns out. So a lot of different things can lead to that drug accumulation. Vomiting, diarrhea, all of that can lead to that, where the levels are going to get too high. And not only that, but if you look at patients who are going to start on other medications like NSAIDs, because we know NSAIDs can decrease kidney function acutely, ACE inhibitors, right, working on the other side of the glomerulus, salt restriction, all of that can be a big problem. Actually, one patient one time who he saw his behavioral health person, got diagnosed with bipolar disorder, been on lithium for several years, decided to go to a new PCP. I guess they didn't do a very good history on him. And so I had a patient with hypertension, started him up on an ACE inhibitor, and all of a sudden the patient's coming in for altered mental status at the ER after starting it. And it's because they didn't do the proper screen to see there being interaction there. Lithium levels were too high. So we ended up having to stop that, give him some IV saline to try to help them clear that the lithium a little bit better, and then get his levels under control. So, and again, this is not metabolized at all, so no interactions from a SIP standpoint to worry about. Any questions on lithium? Let's do a 10-minute break. I'll time it to make sure it's actually 10 minutes, and we'll come back. Okay, so I mentioned lithium was kind of the gold standard for a good long time. Now we're starting to use more of our anticonvulsants for bipolar disorder. I'm going to talk about them briefly here, but we're going to get into them in much more detail in the neurology section, which is this is all going to be on the same test anyway, so don't fret about that too much if we don't get into all the details here. And if you haven't covered any epilepsy stuff yet, right? No, okay. So this will be kind of your first introduction to these medications. Now, one of the more common ones you'll see being used is Valproic Acid. There are several different brand names for it depending on if you're dealing with a long-acting formulation or the liquid. So you see things like Depakote, Depakon, Depakine. If you see like a Depa, that's usually referring to Valproic Acid typically. And so it is used as as a mood stabilizer. If you're using it for epilepsy, obviously it's used as an anticonvulsant. And so this is really good for either acute manic symptoms, they're having sort of an acute issue coming in, or better for chronic therapy as well, right? So you can kind of use it for either one here. Now, we don't know the full mechanism for how it's working for bipolar disorder specifically, but some of it is thought to be doing some mimicry as far as acting sort of like GABA. That's some of these postsynaptic receptor sites. And GABA typically does what in the brain? Slows things down, right? It's the brakes on the system. Typically, when you activate a GABA receptor, what does that do to the neuron? And we'll talk about this at length when we get into the neurology section, but basically it opens up chloride channels, right? You're going to allow chloride to flow into the neuron. And what does that do to the electric potential of that neuron? It's much more negative, and it becomes hyperpolarized, right? It's going to be much more difficult to have an action potential. We'll cover this in more detail, but just know it's going to make the neurons more difficult to fire, so it's kind of slowing everything down, right? So by mimicking GABA, some of these effects here, you kind of slow things down. That makes sense because if you're in a manic state, the neurons are firing too frequently. You're seeing that sort of that increase in activity for the patient. Trying to slow things down is going to be good for them from that standpoint. And we'll talk about kind of acute treatment as well in a little bit, and that'll make sense when we talk about the drugs we use for that. So anyway, keep in mind as well that whenever you're combining these drugs together, so if you were to combine lithium with valproic acid, you're going to see increased risk for side effects due to drug interactions. You're going to see with that. However, this is much better tolerated for the most part than lithium is, but you will see some common side effects, and so this is where you can see a lot of CNS slowing, which can lead to this depressed mental status. You can see things like ataxia, lethargy, and then notably valproic acid is pretty well known to cause hepatotoxicity. Again, good thing to know about valproic acid. You want to check your LFTs whenever you're administering that. And the other big thing you can see is hyperammonemia that can develop, and this is basically due to valproic acid's action in the liver, leading to a relative deficiency of something called carnitine. And you lose that carnitine, you're not able to process ammonia very well, and so you're going to see this hyperammonemia. And we know what happens when you have high ammonia levels. It causes a lot of CNS depression and altered mental status, like things like ataxia, lethargy, etc. So again, a lot of times, a lot of patients who will come in, they may have a normal valproic acid level, but they're coming in because they have slurred speech, ataxia, etc. And then we'll say get an ammonia level, and that's usually elevated. So that's one of the things you always want to check for when you have someone on valproic acid. You know how you would treat that? Have a carnitine deficiency, you give them L-carnitine, yeah. So you ever see levocarnitine? That's something we're giving to help those patients handle that ammonia better, right? So anyway, so again, you want to make sure we're following the hepatic function panels there, and then usually a therapeutic range. Again, I'm not going to ask you to memorize this for the test, but be able to at least interpret if I give you a high level or a low level, kind of what that means for the patient there. Typical range you're going to see with bipolar disorder, and this is pretty variable. Usually lithium, like you want to keep it within a very tight range, that 0.6 to 1.2. If you get outside of that, you're going to see a lot of toxicity. With this one, pretty wide range because it's so well tolerated. The therapeutic index is much wider. You can shoot for much higher levels for some patients, so you may get up to 150, maybe 200 in some patients, and they'll do just fine with it. So, just as an example, if I were to ask a question on a test and to say, a patient comes with a valproic acid level that's 175, normal range between 50 and 125, and so the patient's not having any issues, bipolar disorder is well controlled, what do you want to do with that level? What do you want to do with the dose? You would say, don't do anything, right? Just because the level's high doesn't mean you want to necessarily change your regimen. Okay, treat the patient, not the number. That's a big mantra they're going to realize, is that just because the level's elevated or low or just because it's abnormal doesn't mean you have to do anything with it necessarily. And in fact, this is actually a good case. I was on call for the poison center the other night, and I had a doc call up from the hospital, and they said, hey, we've got this young patient here. He decided he wanted to harm himself, and so he took a bunch of Excedrin. Anyone know what's in Excedrin? Caffeine, aspirin, and acetaminophen. Okay, acetaminophen can be pretty dangerous over the course of a couple of days. Aspirin, is that, anyone know if that's dangerous or not? 100%, that's a very dangerous drug to overdose on. Said he also smoked some pot and then drank a handle of vodka. I think, oh, okay. Guy's having a pretty good night, right? So anyway, so you hear all this, and so someone found him. Someone decided to call 911, so they got him transported to the ER. Okay, they do levels for everything. They do a Tylenol level. What do you think that came back at? 0. Okay. Did an aspirin level. Guess what it came back at? 0. Did alcohol level. Guess what it came back at? 0. So you think, okay, well, this guy did all this stuff, roughly 3 or 4 hours ago. What do you think is going on? Well, how can you tell when the patient's lying to you? Their lips are moving, right? So again, this is a young guy trying to harm himself. He's not in the right state of mind. He's probably just saying a whole bunch of stuff. Maybe did this a couple of days before. Who knows, right? But anyway, but we're going off of the lab values, and it's not backing up his story. So okay, well, let's go ahead and just manage this. So, but the problem is, anyone know what happens when you try to commit suicide or you try to harm someone else? What the police will do to you? They put you under Baker Act, right? So this patient was Baker Act, so he's going to be monitored in the hospital anyway. But he had bipolar disorder on his list of behavioral health issues, and he was on Valproic Acid. So of course, whenever you have someone who's intentionally harming themselves and you have a drug they could have taken, you want to check for it, right? You want to make sure that the level's not too high. So the Valproic Acid level was cooking, was waiting to come back, but the doc also smartly got an ammonia level. The ammonia level came back, usually like anything less than 30 is usually pretty normal. This level came back at 69. So the doc was like, well, what do I do with this level? It's elevated. And I said, well, how's the patient? Is he have any signs or symptoms that are consistent with hyperammonemia? It's like, no, he's just pissed off. He's just mad he's here. He's fighting with the nurses. He can walk fine. He's, alert and oriented times 3. So what do we do with it? So what do you think we did with it? He's asymptomatic. He's got this high levels, or incidental finding. Honestly, we didn't do anything with it. So okay, well, this is not something to deal with acutely in the ER. It's going to be a minute anyway. We'll track the levels. We'll see where they're going to make sure they're not elevating, right? We want to make sure they're not trending in the wrong direction. But that's something you can deal with on the outpatient side. So I said, okay, well, you got this level, but he's asymptomatic from it currently. Just don't do anything with it, right? So again, just because that level's elevated doesn't mean you have to do something about it, okay? So it's incidental finding. He can do outpatient levocarnitine therapy. He's going to stay on valproic acid. This guy's got other bigger issues to work with throughout that time. That kind of makes sense? Yes, sir.
If the patient is symptomatic, they will be seeing CNS depression.
Mm-hmm. Yeah. So you'd expect him to be stumbling around, to be slurring his speech, and again, with that story, you'd expect him to be doing that anyway with all the alcohol and the marijuana and everything else on top of it, but he wasn't experiencing any of that, so obviously something is inconsistent in the story, right? So again, you don't want to necessarily say the patient's lying, but there's inconsistencies there, right? So that's one of those things where the level's elevated, but they're symptomatic. Don't do anything with it, right? Otherwise, we could have given them L-carnitine therapy, could have got that level down, and you go from there, right? So that way, because again, the problem was that the doc was wondering, well, if I medically clear this patient, he's still under Baker Act, right? So he still needs a psychiatric evaluation. I can't do any more levels on him. Like once you medically clear them, you can't really do anything else with them. Otherwise, they're not medically clear. So that's why he was really at that conundrum of like, well, what do I do with this? You know, do I need to actually track this? Do I need to actually treat this? And ultimately, we said no, right? So that way he can be medically cleared that much sooner, and then undergo psychiatric evaluation, get sent off to a behavioral health place, and you know, it speeds up the process, right? So that way you can see more patients, you can get someone else into that hospital bed. That makes sense? Anyway, just I thought it was an interesting case. It was at least somewhat pertinent to what we're talking about here. I will try to limit my tangents from here on out. This is kind of a long story. Anywho, the valproic acid very commonly used for bipolar disorder. Another drug we use very commonly is called carbamazepine, or Tegretol is the brand name you see a lot with that. This actually is pretty structurally similar to the TCAs. Remember the tricyclic antidepressants. Anyone remember what kind of main side effects you see with that? Sedation and anticholinergic stuff. That's kind of the main things you're going to find, at least with therapeutic dosing. A lot of anticholinergic effects, a lot of sedation seen with that. Well, guess what? You can see a little bit of that with carbamazepine as well, because it is structurally very similar to the TCAs there. Again, we're not really sure why it works specifically for bipolar disorder, but for epilepsy, we do know it's going to be a sodium channel blocker. Now, if you remember back to our action potentials, what typically causes a rapid rise in electric potential for a neuron? Increased sodium influx, right? You open up those sodium channels, allow sodium to come in, you trigger off an action potential. When you block sodium channels, you're going to be slowing down that process or stopping that process altogether, and hopefully preventing an action potential from occurring. So that's why I use it for seizures in that way. And we'll talk about this more in depth when we get to neurology. But the sodium channel blockade is the main mechanism of action for carbamazepine. Again, why it works for bipolar, we don't specifically know. We just know that it does work. And typically, we'll use this in patients who maybe are not a good candidate for lithium therapy. So for instance, if you had a patient, you know, and I could ask a test question, right? I could ask what would be the best drug to start out a patient for their bipolar disorder. And I can say, well, they already have cirrhosis of the liver. Their liver function's poor. So you would say no, valproic acid, right? Because that would be a bad option for that patient. And then I could say they have really poor kidney function. You would say that'd be a bad candidate for lithium, because that is entirely renally eliminated. It wouldn't be a good candidate for that. Maybe carbamazepine would be a good option, right? These are things you want to kind of think about. Or if they're refractory, you know, they're on good levels of lithium and really wasn't doing anything for them, could be a good backup option. Now, again, here's the therapeutic range, you know, 4 to 12, pretty tight ranges we're going to be shooting for here. And then with all the, you know, anti-epileptic drugs, you're going to find that typically CNS slowing, CNS depression is a very common thing you're going to see with those. So ataxia, lethargy, etc. One of the unique things you're going to find with carbamazepine is this syndrome of inappropriate antidiuretic hormone secretion, or SIADH. What do you think that causes? So if I have too much antidiuretic hormone, what does that do to the kidneys? I'm going to hold on to too much water. Absolutely right, because remember, ADH is going to be placed into the collecting ducts. It's going to cause the aquaporin channels to be there. It's going to try to hold on to more water. So you're going to try to hold on to more water. What do you think it does to your sodium levels? It's going to dilute it. It's going to dilute it out, and you're going to have hyponatremia that can develop from this, right? So it's a common thing you're going to find. Usually patients will have a euvolemic hyponatremia, and SIADH is a common cause for that, right? So again, sodium levels will be something you want to track with carbamazepine. Actually, see, there's a cousin to carbamazepine that's even worse for causing that, but something you want to watch out for. And also, because it's blocking sodium channels, we'd like it to be just specific for the neurons, but it's not going to do that. So it can also affect where else are sodium channels really important? On the heart, right? So you can see some cardiac conduction delays that can occur with that as well. We saw that sodium channel blockade with the TCAs. This is kind of a bleed over effect from that as well, right? Anyway, other things you can find. This is going to induce CYP3A4, right? Not inhibit, but induce 3A4. And in fact, it can actually increase its own metabolism. That's what we call autoinduction of its own metabolism, in which case you actually have to taper up the dose over a period of a few weeks to make sure that their levels stay consistent, because they're going to be increasing those levels of the enzymes, right? So 3A4 is going to be increased. That means levels of other drugs metabolized by CYP3A4 are going to go up or down. You're going to go down because I'm inducing those enzymes to have more of those enzymes available. You can also see this can be a problem with other anticonvulsants that are metabolized through CYP3A4, which can be problematic, and also oral contraceptives. Again, the estrogen can be more rapidly eliminated. So what do you think that could lead to? Accidental pregnancies, right? And so we know bipolar patients, especially in these manic episodes, what might they be partaking in? Risky behaviors, right? So you would put them on oral contraceptives potentially to hopefully prevent pregnancy, and they maybe are on carbamazepine. No one maybe address that drug interaction there, and they engage in some risky behavior, and then they get pregnant. Not great, right? So what could you do instead? we put them on an alternative, right? So again, when we get to OB-GYN section later on, you'll learn that there's alternative forms of contraception you could use. There's things like intrauterine devices that don't undergo systemic absorption that can be very useful there. There are certain implantable ones you can do that could be good alternatives. We'll talk about those later on in OB-GYN, but just know that this is an important interaction because again, probably one of the worst side effects you can have from a drug is an accidental pregnancy, right? No one wants that to happen. So. Anyway, other things you can find are some of these interactions where you actually have drugs being displaced from binding sites. So for instance, valproic acid, if you were to combine this with carbamazepine, which is not totally uncommon, you'd find that it would displace carbamazepine from the proteins in the serum, and then what could that lead to? You know, yeah, you'd have more physiologically active carbamazepine, which could lead to more side effects. Okay. All right, now oxcarbazepine, the drug brand name is trileptal, is actually a derivative of carbamazepine. The levels you can't necessarily get, can't get a carbamazepine level to detect levels of oxcarbazepine. They're structurally different enough to where they won't cross-react, but just know that it's going to work very similar to carbamazepine. The one thing that would really differentiate its activity is it actually has worse SIDA, so you're more likely to see hyponatremia with oxcarbazepine than you are with just carbamazepine. So just be aware of that. Again, less data with this one is kind of, again, if they've failed other forms of therapy, this is a good backup to that. But again, think about lithium, valproic acid. Those are kind of your most common go-to sort of drugs for bipolar disorder, typically. As I mentioned, more SIDH, very typical, similar adverse effects to carbamazepine there. This one will also not only induce 3A4, but also can inhibit CYP2C19. So you're starting to see how there's some complex interactions that can be going along here. So you as a clinician are going to be expected to memorize every single CYP interaction out there? No, but what can you do instead? Look it up, right? So again, if you take anything away from my hours and hours and hours and hours and hours and hours of lectures, is if you're not sure about something, look it up, right? Because again, you don't want to go with that bravado and say, oh yeah, this is obviously it, and you're not really sure, because it's going to lead you and get into trouble. Okay, other ones you may see being used, other anti-epileptics used for bipolar disorder includes lamotrigine, or Lamictal is the brand name for that. This one is again going to be blocking sodium channels. It also inhibits glutamate release. And glutamate typically does what in the brain? It's excitatory, right? So it's kind of the opposite of GABA, and actually glutamate gets turned into GABA eventually through its metabolism. But glutamate's very excitatory, so if I were to inhibit release of glutamate, you can see how that would be kind of a global sort of negative sort of thing. It would slow things down essentially. This is one that's kind of nice because it has both antidepressant and mood stabilizing sort of effects there, so you can kind of get a little bit of double duty with that. But just be aware that things like valproic acid significantly decreases the clearance of lamotrigine, so you have to make sure you're adjusting your doses appropriately. It's not that you can't use the two together, it's just you need to make sure you're addressing it, make sure you're dropping the dose, usually by half, in fact, because the half-life is actually extending by almost double. And then as far as adverse effects go, lamotrigine, one of the big things to really note about this one is going to be the skin manifestations. Now this can be a severe, something like Stevens-Johnson syndrome, or toxic epidermal necrolysis, which can be life-threatening, but you're going to see rashes seen with this. You can have, and again, one of the things, if you when you educate patients, let them know if you see any rashes, blisters, they're forming here, they need to make sure they're addressing that, either come back to see you or going to the ER, because that could eventually develop into something like Stevens-Johnson. So that could be a very potentially serious, life-threatening sort of thing. You can see with Lamictal. And actually, I saw a case of this not too long ago where I had a patient who's actually being admitted. They were on, they had a genetic disorder where they were very prone to having seizures, and so they had to be managed on 3 or 4 different medications for their epilepsy. And so they came in having severe rashes, skin blistering, and so they were diagnosed with Stevens-Johnson syndrome. They're coming in, and so the question is, well, you know, they have all these drugs on there for their epilepsy, but it's potentially causing SJS. You know, well, if you take them off all those drugs, what would happen? You can go back and having seizures, right, which is typically not ideal for your patients because you're treating for one thing, but then you're causing another problem. So the question was, what do you do with all their home medications, right? So they obviously stopped the lamotrigine. And so I was looking at that and I was like, oh, it's really interesting because you don't see Stevens-Johnson's too commonly, at least in the pediatric hospital. So really interesting. I was like, well, they're on all these other meds. Let me just double check, because one of the things you'll find with a lot of anti-epileptics is they tend to cause a lot of skin manifestations like Stevens-Johnson. So when I had looked it up, I actually found like 1 or 2 of their other drugs that they're actually on still, that the docs said, let's go ahead and continue this, can cause it as well. So you have to call them, let them know, hey, you know, this could be possibly interacting. It's probably the Lamictal, but it could be these other things that are contributory as well. And I said, oh, wow, I didn't even know that. And so they end up DCing, and then we have to put them on alternative drugs there. So again, look this stuff up, even if you're really sure. It's like, yeah, lamotrigine, I know that causes SJS, but there are other things that can do it as well. So you want to make sure you look those things up. All right. So that's it for the mood stabilizing sort of drugs there. Any questions about those? Yes, sir.
When you're talking about the medication to slow things down or inhibit glutamate, slow things down, are you supposed to give those medications in the manic phase of bipolar or the depressive phase?
That's a really good question. Yeah, so we'll talk about that in just a little bit, but typically the question is like kind of what state is the patient in right at that moment, right? So again, if they're in the middle of a manic state, and again, that could be as severe as they're, threatening self-harm or harm to others, really the kind of acute sort of manic breaks, that's going to require very acute sort of attention to that. So we're going to use really the big guns that are really going to try to inhibit things and slow things down very significantly. We'll talk about that in a moment. But if not, if they're maybe in kind of one of those intermittent sort of phases there, you can start them off maybe on lower dose therapies, these mood stabilizers, to try to help prevent them from going into one of those more manic states, right? So again, it all depends. We'll talk about that a little bit more in detail a little bit later on. But yeah, we'll talk about some of the big guns you can use to really knock these patients down, because you have some that will come in there, very dangerous to themselves and a lot of the hospital staff, and you got to do something about them. So we'll mention those in a second. Other drugs you can also use for bipolar disorder are going to include our antipsychotics. Now, these are definitely things that most of your faculty should probably be on. But again, it's like when the patients get the keys at the insane asylum. We're all running the show now, so you guys are our victims. Anyway, so antipsychotics, we're going to talk about these. Again, you're going to find these with use in bipolar disorder, but also you can use it for patients with schizophrenia. A lot of use for these medications here, but basically what we're going to find is there's first and second generation antipsychotics. Okay, have you talked about antipsychotics at all with Dr. Austin? A little bit, maybe? I'm not seeing a whole lot of recognition in your eyes, so I'm going to say no and just act like you haven't heard of it before, so good. Okay, so the first generation antipsychotics, their main mechanism of action is blocking dopamine 2 receptors. Okay, dopamine 2 receptor blockade is the main mechanism of action for the first generation antipsychotics. The second generation group of drugs, which we'll get into more detail and I'll show you what all those are, they will also block dopamine 2 receptors to some degree, a lot lesser degree as you'll see, and that's going to be important for some of the interactions and some of the side effects you see with that. But they also will end up inhibiting 5-HT2A receptors. And 5-HT is another name for serotonin, right? So they inhibit these serotonin 2A receptors. And I said there's a million different serotonin receptors that are out there. This one specifically is serotonin 2A. And so you're going to find that these are either effective for monotherapy or in combination therapy for treating acute manic episodes, right? So if you have a patient who's coming in and they're being very belligerent and they're, threatening to harm staff or maybe are harming staff, some of these are very good for treating that really acute sort of manic phase. Now, if you imagine you have someone coming in like that, who's quite dangerous, maybe they're trying to hit the nurses and whatnot, having to restrain them, what route of drug delivery do you think you want to go with? You want to go oral? Shoot him in the butt. It's the technical term. Shoot him in the butt. It's like what's that Gator show where they're just like shoot him in the head. Like, I don't know. My parents watch a lot of that stuff, so whenever I go home, I'm just like, what is this TV? Anywho, yeah. So you're right. So oral route is probably not going to be very good, right? So just like my 2-year-old, whenever I try to get something orally, guess where it ends up? On me, right? So again, it's not a good route for them. IV, would that be a good route for those patients? If you can get an IV, right? That's the question. Can you actually get an IV? Can it be held still for long enough to actually get an IV placed? So if you can't do IV, what can you do? Shoot them in the butt, right? So you can give them an IM injection. Doesn't have to be the butt. It could be the deltoid. It could be lots of places. But intramuscular injection is very easy. Relatively speaking, you still have to hold the patient down long enough to actually get the injection done, but quick, easy. You can get the patient calmed down, and then you can think about things like getting more definitive access like IV route. So anyway, so again, think about which route the drug's going to be given, because that can be very important. So we have some of these atypical antipsychotics, these second generation drugs that are good IM drugs that we can administer for some of these really acutely manic patients. But very good for treating the agitation, the aggression, the psychosis, because they're very sedating. So we're going to be able to knock this patient down very quickly. When I talk about things like giving a little bit of vitamin H to a patient, that's usually when I'm talking about Haldol or haloperidol. Very good for knocking patients down, because they are going to be pretty sedate after that one, right? It's like getting hit by a Mack truck. They're just going to be nice and sedate, calm down. You can do whatever you need to with them. A lot of adverse effects going to be seen with this, and I'll talk about this in more detail when I get into them. But things like worsening metabolic effects. This is long-term therapy with things like worsening type 2 diabetes, weight gain, dyslipidemia. You're going to find a lot of that seen with the antipsychotics. And again, we'll talk about this much more in detail in just a few slides here when we actually get to talking about schizophrenia. All right, other alternative agents you may see being used for bipolar disorder include things like benzodiazepines. This will get talked about in great detail in the neurology section. I know I keep trying to allude to all these things. I'm trying to keep you guys interested by being like, oh, guess what? Coming attractions. We'll talk about these drugs later. But the benzos are very good at slowing down things. These are going to be GABA agonists. They're going to actually be helping to increase activity of GABA at the receptors to try to increase that chloride influx, to try to slow down those neurons and hyperpolarize them. Very good for acute manic symptoms, right? Good for acute anxiety, but very, very sedating, right? So we'll talk about much more of these in more detail. Oftentimes, patients may be on chronic mood stabilizers, and they'll have PRN orders or PRN prescriptions for benzodiazepines, because oftentimes these drugs are not something you want to take necessarily every single day, but it's something you can use as needed. So hey, if you're getting a little anxious, if you notice, you're maybe hitting into one of those kind of manic phases, take this, right, as needed. Other things you can see, things like calcium channel antagonists. This is used less commonly, but some people believe that things like calcium channel blockers can be used to inhibit neurotransmitter release, maybe some synthesis of neurotransmitters. So things like verapamil actually have some activity here as a mood stabilizer. You may see that occasionally. Nimodipine is another one, which would be a dihydropyridine that can actually get across that blood-brain barrier and have some anticonvulsant properties as well. So that could be potentially used. So generally, you want to start off with a mood stabilizing agent, so something like lithium, carbamazepine, valproic acid. Any of those are totally fine. Or we'll talk about the second generation antipsychotics a little bit later on. Typically, second generation is what you want to go with, and for the most part. If they're having a lot of insomnia, anxiety, agitation, this is where the benzodiazepines can come into play. And then something like oxcarbazepine can be used as an alternative. So if they kind of fail therapy with something like valproic acid, maybe consider oxcarbazepine there. And then, as we mentioned, sometimes combination therapy is necessary, but double check those interactions. Because I've seen cases where someone put valproic acid along with Lamictal, didn't address the fact that the half-life of the Lamictal is going to be doubled, and then they develop toxicity from that, right? So you got to make sure you're addressing that. Check your interactions beforehand. They're having inadequate response. Common double therapies include things like lithium plus an anticonvulsant, or lithium plus a second generation antipsychotic, or you may see something like an anticonvulsant like valproic acid plus carbamazepine, or valproic acid plus a second generation antipsychotic. And again, we'll talk about these later on in this slide set. Okay, so any questions on bipolar disorder? All right, I'm going to move forward. We're going to talk about antipsychotics. This is where we're talking about our drugs used for schizophrenia. So the etiology here, it's probably a lot of factors playing a role here. There's definitely some genetics here, where if you have about a 10% chance of developing if you have a first-degree relative that has it. If you have two, both parents have it, 40% chance, right? So there's definitely some genetic components here, but we really don't know why it occurs here. Now, the thing we're going to be using to treat this, and again, we're going to talk about a couple of different sets of symptoms here, right? We're going to talk about the positive symptoms, the negative symptoms, and then the cognitive symptoms here. We're going to find that these are being manifested through different neurotransmitters. So dopamine and serotonin are going to be the big ones we're going to talk about here. So some people believe there's a dopamine receptor defect, where you actually have hypoactivity of dopamine in some places, but hyperactivity in other places, linked to different sets of symptoms here. So you can see things like dopamine hyperactivity in the caudate nucleus, hypoactivity in the frontal cortex. This is where we think we see a lot of cognitive and negative sort of symptoms that can develop from that. And then there's also mesocaudate here, so we think there's some hyperactivity, and this is where we're going to see a lot of positive symptoms. And I'll talk about what those are in just a few minutes here. And you guys haven't covered schizophrenia yet, right? Okay, so again, this will be your first foray into it. We also think there's probably some glutamate activity that's going to be playing a role here, but the big thing we're going to note is that serotonin and dopamine are our main neurotransmitters we're going to be affecting with our drugs here. Okay, so just note that. So if I were to show you a picture, kind of what's going on here, and we're just going to focus on things that are pertinent to us. Imagine here we have these dopaminergic neurons here, right? These are releasing dopamine. Notice here the receptors that can affect it. Things like nicotinic, acetylcholine receptors, but also we have GABA receptors that are here as well. Normally GABA is going to do what to the system? Slow it down, shut it down, right? So maybe you have underactivity here. You're going to find that you have these dopamine neurons, and again, they can have several different projections. You're going to see here where they will release dopamine on different places. So here we have the frontal cortex. Imagine here if you have hypoactivity, they're not releasing enough serotonin or dopamine here, you're going to end up developing a certain set of symptoms. This also means you're going to have some of these feedback loops that are going to be interrupted. And normally this would be an inhibitory sort of circuit here. With this underactivity dopamine affecting this, you're going to find they actually have too much dopamine being released here, and the nucleus accumbens. Basically, just know that in some places you're going to have too little dopamine activity, in other places you're going to have too much dopamine activity. And our drugs, you're going to find, if I do things like block dopamine, in places where it's hypoactive to begin with, you're going to see worsening of those symptoms, right? So again, it gets very complicated, and we'll get into those drugs in just a minute here. Anywho, so when you develop schizophrenia, oftentimes the brain is going to lose touch with reality. You're going to find they have these things like hallucinations, especially like they hear voices. You can have these delusions, like that I'm a really funny professor. Definitely, delusions of grandeur from that standpoint. All these things are going to be developing. Some of these, when you have things that are present that are not actually really there, when you have these kind of like auditory hallucinations and things, those are what we call those positive symptoms there. Also, their affect is going to be pretty well affected here additionally. So they have a pretty flat affect, maybe inappropriate, maybe pretty labile, going from say very flat to maybe intense anger or something like that very quickly. Also, things like personal hygiene tends to suffer. They're not really taking care of themselves very well. Oftentimes, not really taking holding a job very long or having a stable home life. Things like that can be a big thing here. So oftentimes these patients are very difficult to treat additionally because if they don't feel like they have an issue, do you think they're going to be compliant with their medications? Not really, right? So again, they're going, well, I don't need these medications. The voices are telling me that I'm totally fine. I'm not going to take the medication. So compliance is a huge issue with these patients here, which is oftentimes why we like to go with long-acting intramuscular varieties of some of these drugs. So actually we'll find that some drugs can have a nice long-acting effect, say up to 3 months, where you'll give it to the patient, inject it into them, and then that way they don't have a choice but to be compliant for that 3-month period. So sometimes you'll see that. But oftentimes they have a very high rate of substance abuse additionally, so not only can they have these symptoms here, but they can be aggravated by things like ethanol abuse, nicotine abuse as well. It's pretty rampant amongst these schizophrenic patients. So getting into the different symptoms here, and again, we'll mention certain drugs are better for different types of symptoms, as we'll see in a moment. Positive things are things that are there for the patient that aren't really there, right? So things that should not be there. Things like having these sense of paranoia, hallucinations, unusual thought content, things like that. The negative symptoms are things that are missing that should be there, right? So for instance, they have this very flat affect, that's anhedonia. Anyone know what anhedonia is? Besides my metal band in high school? This is lack of feeling pleasure with things, right? So you go sit on a roller coaster and you're just sitting there not having any fun. Right? It's anhedonia, right? Avolition, they don't really have really the motivation to actually carry out actions, things like that, right? So these are things that should be there that are missing, right? Those are those negative symptoms, oftentimes due to dopamine hypoactivity or underactivity in the frontal cortex. And there's cognitive effects here as well, which is probably mediated through the frontal cortex, things like impaired attention, memory, etc. Okay, so those are the main varieties of symptoms. Now, which ones do you think can tend to be most dangerous? Probably the positive symptoms, right? So again, if you are having these hallucinations and they're telling you to harm yourself, those can be very dangerous, right? So when you have a patient who's presenting, say, for instance, to the ER, where I saw a lot of these patients, oftentimes the positive symptoms are the things that are most dangerous that you need to deal with very much acutely. However, the cognitive negative effects are things you're going to be dealing with for the long term as well. So again, which drugs we use is dictated based on how the patient's really presenting. So our desired outcome, obviously we're going to find that pharmacotherapy is going to, oh yes ma'am.
Sorry, for positives and negatives, does positive correlate to too much dopamine, and then negative is not enough?
Yeah, so it depends on where you're talking about in the brain. So like we mentioned in the nucleus accumbens, you had too much dopamine activity causing positive symptoms, and then in the frontal cortex, you had dopamine hypoactivity leading to those negative symptoms. Absolutely, yeah. So it could be either or in those cases there. But you can imagine if it's you're dealing with the positive symptoms and you're decreasing dopamine activity, well, that's going to do it globally. And so that means the negative symptoms can be even worse, right? You're going to see even worsened effects from that. So again, it can be difficult when you get to the pharmacotherapy. But pharmacotherapy is key here, right? Most patients are going to need to be managed on some form of medication. Does that mean that's the only thing we're going to do? No, we're going to use things like cognitive behavioral therapy is going to be playing a role here as well. But you need to be really assertive with your therapy in the first 5 years or so. You want to kind of get that under control before a patient has, a lot of, their social, settings can really go down the drain there. So again, a lot of deterioration can happen there. So you want to start early and start heavy. Typically, you need to target what symptoms you're really looking for, right? So if they're presenting to the ER and they're a harm to themselves or others, you got to deal with those positive symptoms first. That's the acute thing you got to deal with. If they're just presenting to your clinic, behavioral health clinic, and they're just now starting to get the diagnosis, they have this kind of flat affect. Those are the things you can deal with more on the chronic sort of sense there. So again, it all depends. But typically, usually about 3 months or so is kind of the time frame to really see how the patients are really going to be responding to these medications. We'd like to minimize adverse effects. However, the drugs we're going to use here are just ripe with adverse effects. You're going to see there's a lot of problems with this, which is, again, is a problem because if the patient doesn't think there's anything wrong with them, and you're giving these medications that's making them feel worse, Again, compliance is going to be a big problem here, right? And then obviously we want to hopefully decrease hospitalizations if possible. Achieve good compliance. Sometimes we have to use different routes of medication administration to do so. Hopefully decreases recurrent episodes, right? Anyway, so getting into the different classes of antipsychotics, there's going to be the first generation and the second generation. First generation is also sometimes called the typical antipsychotics. Second generation is sometimes called the atypical antipsychotics. Okay. So the first generation ones, their main mechanism of action is to decrease activity at the dopamine 2 receptor. So these are going to be dopamine 2 receptor antagonists. This means they're going to be blocking the effects of dopamine, which means they're very good at decreasing the positive symptoms here, right? So decreasing that nucleus accumbens dopamine signaling by blocking those receptors. So it could be releasing all the dopamine at once, but the receptors are going to be occupied by these drugs here. But as I mentioned, by doing that, it'd be nice if I could just target those dopamine receptors in the nucleus accumbens. I can't do that, though. The drug kind of acts everywhere. So you're going to find it's going to worsen a lot of those negative symptoms, right? So that avolition, the anhedonia, that flat affect is going to be worsened by these first generation sorts of drugs, okay? Again, so by blocking this dopamine activity right here, you're going to be decreasing those positive symptoms, okay? So you can imagine these receptors being blocked up by the first generation antipsychotics. However, it's going to be worsened here because you're going to have less activity at the frontal cortex, right? Okay, so adverse effects, things we're going to be seeing here. So when you block dopamine, typically you're going to find a reciprocal increase in prolactin. Okay, so you're going to find hyperprolactinemia that can occur here, which can lead to things like menstrual irregularities, can lead to infertility, can lead to gynecomastia. Okay, does anyone know what you give when you have patients who have hyperprolactinemia and they can't get pregnant? What do you give them? They should give them dopamine agonist. You can do the opposite effect here. You actually give them dopamine agonists to decrease prolactin levels. So again, there's kind of a seesaw sort of effect between dopamine and prolactin. So when I decrease dopamine activity, you're going to find increased prolactin levels. Okay, so menstrual irregularities, like gynecomastia, is most often seen there. Okay, other things you're going to find is another seesaw sort of effect, and this will become more prominent when we talk about Parkinson's disease in a little bit. Is going to be the seesaw effect between dopamine and acetylcholine. If I block dopamine, you're going to find there's increased acetylcholine activity. We'll talk about those side effects and how that manifests a little bit later on here. And then the main thing that's going to manifest as by blocking dopamine is going to be what we call these extrapyramidal side effects. I've never heard of EPS or extrapyramidal side effects before. It's a very common set of symptoms or side effects that are associated with these first generation drugs here, right? And basically, and if you think about Parkinson's, what is Parkinson's essentially? What's the pathophysiology there? Lack of dopamine, right? You lose those dopaminergic neurons. Well, I can basically induce Parkinson's in a patient by blocking the same dopamine receptors, okay? So whenever I give a patient a first generation antipsychotic, you're going to see signs and symptoms that look a lot like Parkinson's, right? It's associated with that. So things like catatonia, you're going to see this motor rigidity here. You're going to see tremor associated with that. A lot of tremor is actually due to acetylcholine, and we'll mention that in neurology later on. But you can also have this dystonia. That can be pretty problematic for the patient. Oftentimes, it's these involuntary muscle contractions that occur usually in the face, the neck, or the tongue muscle, but you can really see it anywhere potentially, but usually those most often get affected. Kind of a funny story, maybe not funny for the patients, but funny as the providers, it was actually a family that came into the ER one time. It was a mom, a dad, and a son. Basically were coming in, and what they had thought they had taken was Valium. Valium is a brand name for diazepam, which is a benzodiazepine, right? And we mentioned that's usually going to be slowing down the system. It's kind of like getting drunk a little bit. And so what they thought, they bought some diazepam off of the street. The pills looked right. So, okay, we're going to take this. All of a sudden, they come into the ER, and they have all these protrusions are happening. So basically, they're kind of catatonic almost. I guess a family that does drugs together stays together, I guess. But basically, you have these three people you're treating. And they're just like, well, what in the heck's going on? And in fact, one of the things you can do to treat these dystonias is actually give them Valium. So we're like, well, what in the heck's going on here? It's completely opposite of what we think. So fortunately, they had some of the pills left over. And so we took these because, again, they were pretty scared and they were worried about what was going on. So they're actually pretty forthright with what was going on, the history. We took the pills, actually did a pill identification. Guess what? It also turns out that the manufacturer makes their Valium look just like their haloperidol or Haldol. And we're going to find that Haldol is actually one of these first generation antipsychotics that's very well known for causing EPS. So basically what they had done is it basically induced a Parkinson-like syndrome in themselves by taking these drugs that they should not have taken. There you go. So again, don't do drugs. That's another thing you can take away from this class. Look stuff up and then don't do drugs. Right, so again, these dystonias are very, very common. You're going to see with these EPS, especially if you have patients who, are coming in with an acute psychotic break, are danger to themselves and others. Give them a big dose of haloperidol. Oftentimes, you can end up seeing these extrapyramidal side effects develop from that. So very commonly seen with the first generation antipsychotics. Other things we can see, we have what we call akathisia. Anyone remember what I described akathisia as? Can't sit still. A lot of you probably have some akathisia right now. You're like, I just want to, when's he going to go to breaks and get out of here and walk around? That's that restlessness, that agitation. A lot of pacing kind of goes along with that. That's another thing you're going to find with dopamine receptor antagonists is going to be the akathisia. Usually not too big of a problem, but the patient feels pretty uncomfortable. And then what we have with long-term therapy is what we call tardive dyskinesia. Tardive dyskinesia is basically what happens when you have this chronic dopamine receptor antagonism, leading basically to this upregulation of these dopamine receptors. Your body becomes very, very sensitive to dopamine, and so what you end up developing, are some of these inappropriate muscle movement, right? We know dopamine is really important for causing the muscles to move, essentially, right? And so you're going to see things like these, this kind of chronic chewing or licking motion that kind of have this involuntary control. Maybe sticking their tongue out, things like that. You'll have this limb movements that they're not really initiating themselves. This is an irreversible sort of phenomenon. So when you have patients who are on these first generation antipsychotics for a long period of time, the EPS, that can go away, that's reversible. But the tardive dyskinesia is something you're going to find is going to be irreversible for these patients, right? It's a long-term sort of thing. Again, don't necessarily like the first generation drugs because of these long-term sort of effects here. So that's why the atypicals are so nice, because you're going to find you actually don't have a lot of the same issues there. Anyway, we're talking about treatment for those side effects in just a little bit later, but actually this is not managed the same way as the EPS is. And actually you can make it worse if you were to treat these the same way. We'll talk about that a little bit later. Okay, other effects you can see with antipsychotics, especially the first generations, they are very dirty in as far as what receptors they're going to be interacting with. Sure, they block dopamine 2 very significantly, but they're going to interact with a lot of other receptors as well. So for instance, some of them can block alpha-1 receptors. That leads to hypotension, postural hypotension, right, dizziness, falls, things like that, so you have to be worried about that. And then a lot of them have anti-muscarinic activity, okay? We all know the mnemonic for that. Mad as a hatter, blind as a bat, etc., right? So I don't have to belabor that point. This is actually good in some cases because this can actually help to block that increased acetylcholine that you see due to that dopamine receptor antagonism. As I mentioned, when you block dopamine receptors, you're going to have an increased release of acetylcholine. And so by giving something that's an anticholinergic, guess what? You block a lot of those effects. So that can be somewhat useful in some cases. But in other cases, it can actually worsen tardive dyskinesia. We'll see a little bit later on. So other things, you're going to see some histamine receptor 1 antagonisms. You're going to see a lot of sedation seen with that. You can see some weight gain seen with this. And then most of them do typically have some cardiac effects. So you can see things like QT prolongation. See sodium channel blockade, which can lead to QRS prolongation, can lead to some arrhythmias. Tachycardia can be seen, usually due to the antimuscarinic sort of effects. So you got to be careful with these, because again, these are also drugs that are prone for people to overdose on. Either if they're taking it for their depression and they end up taking a bunch of them, or if they're taking it for schizophrenia, whatever the case may be. These are drugs that are very frequently overdosed upon by these patients. So that can lead to a lot of cardiac issues. And again, imagine if you had someone who was on, say, for instance, amitriptyline for their depression, they're on, say, lithium for their bipolar disorder, and they happen to be on one of these first-generation antipsychotics, and they took them all together. It gets pretty difficult to manage those patients because, again, they have a lot of different competing drugs all interacting with one another, causing a lot of these effects here. And so, that's what drove me to toxicology in the first place. I was kind of like, wow, these drugs are really cool at therapeutic doses. What happens if we jack everything up to like 11? And so it's really interesting seeing these patients, see how everything kind of interacts with one another. But it can be very difficult to manage, as you'll see. Anyway, another big thing you can find that is unique to this dopamine blockade with the first generation drugs is what we call neuroleptic malignant syndrome, NMS. Now, this is actually going to look a lot like serotonin syndrome. So if you kind of go back, if you remember, what do we say serotonin syndrome looks like? What do they manifest? Usually things like, yeah, they develop clonus, hyperthermia. The hyperreflexia kind of goes along with that clonus and that increased muscle rigidity. Usually autonomic instability and altered mental status, right? Those are kind of the 4 cardinal signs you're going to find with serotonin syndrome. A lot of that looks very similar to NMS, but I'll talk about a few kind of key differences there. Basically, this is seen with drugs that are very, very highly potent at blocking the D2 receptors. And I'll kind of show you a chart in just a few minutes of the different first-generation antipsychotics. Some of them are very highly potent D2 blockers. Some of them are less so. They're going to be much more on the anticholinergic sort of side. So you're going to find there's kind of a spectrum that we'll see here in just a few minutes. But the ones you see this most commonly with are going to be haloperidol and then another drug called flufenazine. Haloperidol is probably the one you're going to run into much more commonly in the clinical setting. But it can occur with any agent. Any drug blocking dopamine 2 receptors can cause this. And basically what you end up developing is this hyperthermia, this altered mental status, and hypertension, another big thing. And then the kind of the notable thing about this is this lead pipe rigidity. I've actually seen this a couple of times in the ER. And it's very kind of interesting because you'll be interviewing the patient, you'll be trying to examine them, and then I'll be like, just relax your arm. And they're like, I can't relax my arm. And it just feels like a lead pipe, like it's just so tight. And as you might imagine, if you have that muscle contractions happening so tightly there, the muscle's getting overworked. That's why you end up seeing the hyperthermia that can develop there. Muscle breakdown can occur eventually, leading to rhabdomyolysis, right? Rhabdomyolysis leads to acidosis, can lead to kidney dysfunction, so it can be pretty bad from that standpoint. So again, be aware of this. If you see a patient comes in looking like this, okay, get the drug history, because oftentimes you can kind of key in on something that could be causing that, kind of the smoking gun. So again, if they're on, an SSRI, you wouldn't necessarily think NMS, maybe think more serotonin syndrome. If they're on haloperidol, you'd be thinking NMS, right? So the history is really key to figuring some of these things out, because the pathophysiology is different, so you're going to be treating it differently for the most part. Anyway, so this is the list of your first generation antipsychotics. And again, this is a big list that's been around for quite some time. Has anyone seen the movie A Beautiful Mind? Right, so that actually is about a very smart man who developed schizophrenia, and actually when he goes on some of the drug therapy, you can see a lot of the effects that he actually develops from those drugs. Really kind of interesting. So for instance, I believe one of the drugs he was on was Thorazine or chlorpromazine. It was kind of one of the first ones we had for a while there. The thing to note with this is, one, you don't have to memorize every single one on this list, because a lot of them we don't actually use clinically too frequently. A lot of these are old drugs we don't see used too often. The ones that are highlighted yellow, you do need to know, right? You want to be able to recognize those for testing purposes, right? So chlorpromazine, you still see used occasionally. Things like thioridazine, prochlorperazine. This one I use almost on a daily basis in the ER, because we actually use this a lot for migraines, patients coming in with migraine headaches, things like that. We'll talk about that a little bit later on. Flufenazine and the haloperidol are also very notable, as we'll mention here in a second. So one thing to note here is that all the side effects here are going to be kind of on a spectrum, right? We have our high potency D2 blockers, haloperidol and flufenazine. Notice here, and again, don't memorize, is it 4 pluses or is it 3 pluses for this one particular drug? You're going to drive yourself crazy doing that. No pun intended, talking about schizophrenia. But just note that haloperidol, flufenazine, these are the big deals when it comes to dopamine receptor blockade. These are where you're more likely to see extrapyramidal side effects. You're more likely to see NMS develop from this because of the high potency D2 receptor blockade. Okay, the other ones tend to have a little bit more on the spectrum going towards anti-muscarinic sort of effects there, right? So looking at things like chlorpromazine, you're going to see more anti-muscarinic activity. You're going to see thioridazine is really big for this as well. You're also going to see more effects on alpha-1 antagonism. You're also going to see more histamine antagonism. So because of that, you're going to see more of those things like the weight gain, the sedation, those sort of effects. You're less likely to see EPS, less likely to see things like NMS develop from that. Okay, so again, it's all kind of on a spectrum, but again, the key takeaways I would at least want to know is that flufenazine, haloperidol, high potency D2 blockers, much more likely to see EPS and NMS. The other ones tend to be much more anti-muscarinic, antihistaminic. That's where we're going to see a lot more sedation, things like that. Same with it. Okay, now does it mean the haloperidol is not going to make you sleepy? No, it's definitely going to knock you out, because I've seen, like I said, when you give a little bit of vitamin H, the patient's going to be sleeping pretty well for a while there, right? But again, it's all on the spectrum here.
Back when we were doing learning about the vertigo, we learned you can take compazine for nausea.
Mm-hmm.
How often is it used for just your basic nausea, vomiting?
It depends. And when you're looking at these drugs, the chemical classification you may hear for these first generation drugs are the phenothiazines, right? So prochlorperazine falls into that category. Promethazine also falls into that category, right? So promethazine, one thing you can actually see is extrapyramidal side effects, because it does have a little bit of dopamine receptor blockade, right? Because that actually helps out a little bit with the nausea, vomiting. The antimuscarinic stuff also helps out with the nausea, vomiting pretty significantly. So it depends on what does the patient respond well to, right? So if they have this being more of a chronic problem and they respond very well to that, then give them that, right? Oftentimes I will tell you though is that at least for nausea, vomiting, just strict nausea, vomiting, gastroenteritis related or whatever, things like ondansetron or Zofran are much more commonly given because it lacks a lot of these extra side effects, as you'll see, right? Anyway. And this table here is going to be important as well when we talk about our atypical drugs. You can see the atypicals listed on this drugs here. But again, looking at the side effect profile, right? Notice here, chlorpromazine, thioridazine, high on sedation, you know, relatively low to moderate for EPS, high on the anticholinergic sort of thing, side effects. Orthostasis is higher here versus things like haloperidol, very low, very high on the EPS, right? So again, it's all on the spectrum based on their receptor activity. So that's kind of the key takeaway I want you guys to notice from these charts here, okay? We'll talk about the atypicals in just a few minutes. So let me finish up with the first generations and I'll give you guys a break. But these are very, very effective for the positive symptoms. These are very good for patients who are coming in with an acute sort of issue where they're having these acute hallucinations, these acute delusions, things like that. Very good for dealing with that. However, a lot of side effects, so very poor from a long-term sort of maintenance standpoint. A lot of times patients are going to discontinue early, and what you want to do is try to pick your drug based off of the patient's symptomatology, right? So they're having a lot of the positive symptoms. Let's go ahead and give them something that's going to be more potent at blocking those dopamine receptors. That's why we're going to use something like haloperidol, much more likely, versus if it's something more the cognitive effects, more the negative effects, so maybe using something with more anticholinergic activity is going to be better for those patients there. Okay, so again, it's all on the spectrum. Any questions from the first half there? I'll tell you, one of my favorite patients I ever had in the ER was this guy. We had morning rounds because I was teaching hospitals. So we had morning rounds in the ER at 7 a.m. So we were there, and there's this guy he'd been there for like an hour or so, you know, for just acute agitation. Didn't know his full history, but he was there and he was just screaming at everyone. He was threatening violence. The staff nurses couldn't get near him. He was like, "I'm an atom bomb. I'm about to go off." And I'm about to blow up. And when I blow up, you guys are not going to see this. And I'm going to, you know, he's just like, that was just going off. I mean, he just constantly would not stop talking. So we're sitting there trying to rounds, talk about patients, and you know, it's just like, what the heck's going on with this guy? And so anyway, he's like, "I'm about to blow up, and I'm gonna just." And we're like, "Oh, what happened?" They're like, "Oh, they gave the Haldol." We got close enough to finally giving him a little shot in the butt, as you said, and there he goes. So anyway, very good drugs for helping to deal with those really acutely agitated sort of patients. But anywho, so what happens when you have the side effects? EPS, right? There's extrapyramidal side effects. Again, that's due to that dopamine 2 receptor blockade. Again, this is where you see those dystonic reactions, that akathisia that can happen from there. This is typically treated with anticholinergics. Remember we said when you block dopamines, that seesaw effect, you're going to see more acetylcholine activity. By giving antihistamine, which typically a lot of our first generation antihistamines have a lot of anticholinergic activity, you're going to find that you can help to mitigate a lot of these symptoms here, which is why if you ever had someone, and as I mentioned, that family who had taken that Haldol on accident with those acute dystonias, basically what we did was give them IV Benadryl. By giving them diphenhydramine as a first-generation antihistamine, has a lot of anticholinergic activity. It helps to decrease that acetylcholine activity, helps to relieve those dystonias, right? So we give them that. There's a couple other drugs you can use as well. These are more purely just anticholinergic drugs. We have things like trihexyphenidyl, which is known as Artane, and you have benstropine or Cogentin. All these are going to work just fine for the patient, and very frequently, some people will get the idea that, okay, I'll just give them a dose of Benadryl, they'll look better, you know, they'll have that, the dystonia will kind of resolve, and then they'll just kind of leave them to it, right? They may just say, oh, let's go and just discharge the patient. You have to remember to at least give them at least 24 hours worth, because otherwise the dystonias can come back because the drug, you know, the antipsychotic is still in the system. So I want to make sure at least give them 24 hours of therapy, but that is going to be the mainstay of therapy for that, okay? So again, if you have acute dystonias, antihistamines, antimuscarinics are basically going to be the treatment of choice for that, okay? If above all else, if that fails, you could also use benzodiazepines. Those are very good muscle relaxing sort of agents that could be used additionally. For tardive dyskinesia, again, this is more of the chronic long-term effects of blocking dopamine. You're going to typically find that you want to avoid anticholinergics, because this is actually the opposite problem. So given an anticholinergic would actually make their issues worse, as the case may be. Oftentimes what we'll do is either try to discontinue therapy if possible. Oftentimes that's going to be a problem though, because guess what? Their schizophrenia is still there. So you got to treat them with something. So very frequently we'll switch them over to a second generation agent. Now back before the second generations were around, you really didn't have a lot of alternatives. And so what we would sometimes do is called drug holidays, right? Which is not just another term for spring break. Often we give them holidays where you give them a period of time where they would kind of wean off the drug, kind of reset themselves a little bit, and then come back on it, right? So again, you're monitoring them closely to make sure they're not having any relapses, but by kind of relieving the body of some of that drug effect for a period of time, hopefully you can kind of try to stave off that tardive dyskinesia. But again, for a lot of patients, this may be irreversible, so something you want to avoid if at all possible. For NMS, in some ways this is treated very similarly to treated very similar to serotonin syndrome, but there's going to be one key distinction here, as I'll mention in a second. Obviously, if you can discontinue the offending agent, that could be a problem, though. So, for instance, if I were using a long-acting form of, say, for instance, haloperidol is a very commonly known antipsychotic to cause NMS. If I were to say give a patient an IM shot of that that's meant to last for 3 months, that could be a problem, right? That's why you don't want to start off a patient on that long-acting form. You want to give it to them orally first to see how they tolerate it. But you want to discontinue the offending agent. Because they're hyperthermic, you need to cool them off. We talked about some strategies to do that, either with evaporative cooling or the ice packs, cooled IV saline, things like that. And then hydrate the patient, obviously. That helps to keep the kidneys nice and perfused, so that way that myoglobin doesn't sit there and clog it up. Yes, sir?
So just going back to what you said about the tardive dyskinesia.
Yeah.
Is there like a set time where we switch over to the other agent, or is it just whenever they exhibit symptoms, then you start considering it?
So I will say nowadays the most common thing you're going to find is that most patients will get started on a second generation first. So these are not really the first line therapy they were back in the day. So certainly though, if you had a patient who maybe was very treatment resistant to the second generation drugs, the atypicals, and you had to give them something like chlorpromazine for the long term, once you started to notice the effects recurring, maybe you would try to say switch them back over, right? But it's something you just know is going to happen with longer the duration of therapy is, the bigger the dose, you know it's going to happen eventually, right? So it's one of those things where it was tough because, you know, it's a double-edged sword, right? You know, you need to treat the schizophrenia, but you know the start of dyskinesia is going to happen eventually. Yeah.
So then in practice, you don't really do it that way?
Yeah, in practice, we would typically start off with the second generation agent first, see how they're going to tolerate that. And most patients do typically do very well with the second generation agents. And again, that's why you're going to see the second generations pop up in a lot of different things. Like we mentioned treatment resistant depression, we mentioned bipolar disorder. They have a lot of double and triple duty that they can pull. They're much better tolerated. We use this a lot more frequently. These are kind of gone by the wayside a little bit. But you still use it clinically. As I mentioned, like, you know, if you go to any ER, you're going to find a lot of haloperidol there because, you know, you have to use it for some of those more acutely agitated patients for sure. Yep. And then whenever says they have a haloperidol allergy, like, you know, they've seen some stuff, right? So how did you find that out is the next question you want to ask, right? So just be careful with that. Anywho, so you want to cool down the patient. There's actually a drug we have called dantrolene, which is useful. It's a skeletal muscle relaxant. And basically what this is going to do is to help relieve that lead pipe rigidity. And because, again, that's the kind of the baseline problem. Those muscles are too overcontracted. They're going to eventually wear out and cause breakdown. So by giving dantrolene to relax that muscle is going to help to fix that. There's also something that we'll talk about later in the surgery section called malignant hyperthermia. That's the other place you're going to see dantrolene being used as kind of the go-to drug there. So something to know. And then we said that, you know, NMS happens due to dopamine receptor blockade. Well, we can get something to activate those dopamine receptors and hopefully reestablish normal activity. And that's where we can give a drug called bromocriptine, which is a dopamine receptor agonist. Okay, so it's kind of the alternative you could do. And so most of the time, though, most patients will just give them, you get them cooled down, give them some dantrolene. Most of the time they're fine, but occasionally we'll have to use bromocriptine. Okay, so refer back to this table. We've kind of gone over all this already. We've kind of talked about most of this. Just know that know why the adverse effect is occurring. Know whether it's due to that dopamine blockade or whether it's due to, say, for instance, with tardive dyskinesia, more of that dopamine receptor sensitization, and know how to manage it, right? So again, if I have a patient, if I give you on a test question, patient comes in, they're having this acute dystonia, they're having this tongue protrusions, they just took a dose of haloperidol. How are you going to manage that? And you would say, give them Benadryl, or I give them an antihistamine. Or I might have other options on there. I might say give them a drug holiday. I might say give them, bromocriptine, I say something, and you'd be able to key in, okay, this is an acute dystonia, it's acute extrapyramidal side effect, I'm going to give them an antihistamine, right? So again, it could be an example of a question I may ask on a test, right? Actually, I had one really interesting case that happened when I was in fellowship. There was I believe it was like a 6-month-old or something. The mom had a host of mental health issues in addition to having significant drug abuse, but she had the 6-month-old at home, and basically the call that we got was saying that the EMS was transporting this baby who was having what they call epistatonus. I've never heard of that term. If you look it up on Google, you'll see this like kind of classic painting of this guy who's got this very serious back arching that's occurring. But basically, it's a significant muscle contractions, typically causing a lot of back arching, right? Because again, all those muscles in the back are contracting all at the same time. This kid, this 6-month-old, was having this, and we're trying to figure out, well, what the heck is going on? So the drug exposure was a possible risk. Basically, the mom had gone into the bedroom, shut the door, said she didn't want to deal with the kid anymore. He got into mom's medications. And so they're trying to figure out what the heck it was. And so all we heard from EMS was they said it was Nubane. The mom had Nubane. Well, if you know anything, Nubane is an opioid analgesic. And we're like, well, that shouldn't cause that. Like, it didn't make sense. You're like, what the heck is going on? And again, you always are working with half the history, right? You're only working with bits and pieces of information. So what we'd actually figured out, once we were able to get a better idea of what the mom was actually taking, was a drug called Navane, which is a brand name for one of these first-generation antipsychotics. So once we figured out why that kid was having the back arching due to extrapyramidal side effects from this Navane, we were able to give them Benadryl, relieve the muscle contractions, and the kid did fine. So again, you got to make sure you're trying to piece through, see why things seem consistent or inconsistent, and that can lead you to coming up with a definitive diagnosis and what the actual treatment is going to be there, right? Because again, you could have given them some benzodiazepines to try to deal with that muscle relaxation, but it wouldn't have been fixing the root cause problem there, right? Due to that acetylcholine affecting those nicotinic receptors. Okay, make sense? Anyway, so again, refer back to this. This will be a good chart to review for testing purposes. Again, if you have a side effect, how are you going to deal with it essentially? Okay, so getting into the second generation agents, you're going to find these being used much more commonly. You're going to see them used for a lot of off-label sort of uses, so things like treatment-resistant depression, etc. And so another name again is the atypical antipsychotics here. These have much fewer side effects associated with extrapyramidal effects, much less prolactin level increases, because you're going to find while they have a little bit of dopamine 2 receptor blockade, that's not the main feature, right? That's not the main mechanism of action of these drugs. The main thing they're going to be doing is blocking those serotonin 2A receptors. Okay, that's the main activity. I'll show you that chart again in a second so you see where they're working. These are going to be much more efficacious for the negative and the cognitive symptoms. Again, when you're looking at the first generation, they were great for positive symptoms, but actually they could worsen the negative and the cognitive effects here. This is actually going to be working on all of them, as we'll see in just a moment here. Much less tardive dyskinesia. A lot of patients will not develop tardive dyskinesia with prolonged use here, and this should be used first unless otherwise contraindicated, right? So if you could not use the second generation, that's when you'd want to switch over to first generation, but nowadays most patients are managed on these. So, as I mentioned, much less activity on the D2 receptors. This is going to have much less EPS. In fact, I don't know that I've ever seen a patient have an acute dystonia associated with a second generation agent. The main thing they're doing, though, is blocking that serotonin 2A receptor. Okay, again, it's going to be mainly affecting that cortex, and we'll see how it's going to help with the positive symptoms here in just a moment as well. So, if you're looking again at this chart, if you imagine, you see here, let me get the laser pointer. Notice here the serotonin 2A receptors right here. Notice here that negative sign. That means it's an inhibitory sort of receptor. So if I were to inhibit, if I were to release serotonin here, this would have a negative effect, and we have less dopamine release, right? We mentioned that's what causes a lot of those negative symptoms, is that lack of dopamine activity in the cortex, right? Well, if I go ahead and inhibit this, if I were to block up that receptor, they're going to find that this will lead to more dopamine being released here, which is good. So you're going to release more dopamine. It's going to be activating this. You're going to be relieving those negative symptoms, those cognitive symptoms. And additionally, you're going to find that by working on this as well, you're going to eventually lead to decreased effects here, because this is another negative inhibitory sort of neuron here. By activating it, you're going to be releasing inhibitory neurotransmitters here. That's going to be decreasing dopamine release from this one. Right? So now you can see by working on this receptor right here with serotonin, you affect both frontal cortex activity. You fix that problem by releasing more dopamine, and then through this this circuit here, you're going to find you're going to be decreasing dopamine release in the nucleus accumbens. Okay, so that way you deal with the positive symptoms as well. That's why they tend to be so effective. So side effects you're going to be seeing with this. These are going to be much more important for the chronic use of these drugs from a metabolic standpoint. So a lot of them tend to have a lot of weight gain associated with them. This is going to be highest with the olanzapine. It is not uncommon for a patient you start on olanzapine to end up gaining 10, 20, 30 pounds, right? Oftentimes, if they gain more than 5% of their baseline weight, typically you need to switch them over to something else, right? So it's a very common side effect you're going to see with those. Probably lowest with something like ziprasidone and aripiprazole. Again, I'll show you the chart in a few minutes. It gives all the second generation drugs. So the lowest incidence there. You can also find that it can lead to glucose intolerance, which can actually induce type 2 diabetes or uncover maybe in some patients, especially clozapine tends to be more common with that. And then you're going to see some hyperlipidemia. Okay, and again, this is in addition to if that patient had any of these effects to begin with, right? And again, most of the time they're not taking care of themselves very well. They're probably not eating right, so they probably have some of this at baseline anyway, and this is just going to potentially worsen it. A unique thing with one of these called clozapine is agranulocytosis, and this is actually a 1% incidence, which doesn't sound like it's too much, but 1 in every 100 patients. Like, it's a little too risky. This is actually going to be a drug you want to reserve for patients who have failed probably 2 or 3 other drugs. So you really want to hold off on using clozapine because of this incidence here. And so because of that, there's actually a REMS program. You guys remember REMS programs mentioned before? What are those? Risk evaluation and mitigation strategies, right? So they try to mitigate the risk associated with some of these drugs. So remember Accutane. What do you have to do when you're on Accutane? Pregnancy test, you have to go to all, you have to be registered, the provider has to be registered, the pharmacy has to be registered, patient. Same thing happens here with clozapine, because you have to make sure the patient's going to be coming in to get those CBCs done and make sure they don't develop this agranulocytosis. Because they develop agranulocytosis, what happens then? They don't have an immune system, die from infection, right? So you have to make sure you're monitoring that. We already said adherence for a lot of these patients is very dodgy in the first place. So again, if they're not coming in to get those labs done, they don't want to be giving those patient those drugs, right? So clozapine is a unique thing associated just with that drug. Other things you can see, cardiac effects, including QT prolongation. So most of the second generation drugs will cause some QT prolongation. Now again, is this a problem in and of itself? Not usually, but again, when you start to mix other drugs together, this is where you can run into issues, right? So again, if I were to say have a patient either take an overdose of one of these, that can be a problem, or if you were to mix and match several of these together. So for instance, I had a patient who had depression, and they were on an SSRI. Anyone remember the SSRI that causes QT prolongation? There's 2 of them. Citalopram and escitalopram. If I were to mix that on top of something like quetiapine or aripiprazole or something like that, that's where you can start to see issues there, right? So again, a lot of these patients, you got to make sure you're getting baseline EKGs, and then you can monitor if you're concerned about things like overdoses and whatnot, right? You see some orthostatic hypotension, so a little bit of alpha antagonism you can see with these. Most often you're going to find this more common with like IM and IV doses. When you get that big dose all at once, they tend to see a little bit more of that. And then also elderly patients tend to be more at risk. You have to be careful with those patients. Typically over the course of 2 or 3 months or so, they should become pretty tolerant to it though. Now, one thing to note is that there's a black box warning for these drugs, that you do not want to use this to treat elderly-related dementia. Okay, so we know, especially patients who end up in the hospital, again, my experience where I speak most from, these elderly patients, when the sun goes down, what happens with them? They get a little kooky, right? So you get this dementia that can be worsened by the fact they're in an unfamiliar environment, they're surrounded by unfamiliar people, they're probably sick with something, either infection or otherwise, and so they can have this ultramental status. They can become agitated, can become potentially violent in some cases. Your gut reaction is to say, well, let's give them an antipsychotic to manage that. You do not want to do that, because there's actually been an increased risk of death seen with those patients, enough to where the FDA went ahead and put a black box warning on these drugs. There are other drugs you can use. We'll talk about those later on, but antipsychotics are not going to be the agents to use for those. This applies to both second and first generation agents. Okay, so just note that. Other big things include sedation, so especially things like quetiapine, olanzapine, clozapine, all tend to cause pretty significant sedation, and so often we'll give them at bedtime, right? So QHS dosing, give them at nighttime to help kind of mitigate some of that. There's actually kind of a funny comedian I was listening to at one point. He says that he was at his girlfriend's house at the time, and there was this like construction that was going on outside. It was just keeping him up all hours of the night. Just couldn't get any sleep. So his girlfriend was like, "Oh, well, here, take this." It was a Seroquel, brand name for quetiapine. So here, take a Seroquel, it'll be fine. And so he said he was, okay, so he took it and went to go to the bathroom before he went to bed, and he fell asleep standing up, caught himself right before he hit the wall, right? So wow, this stuff is really, really good for sleep. Like, holy cow, I slept better than I ever slept in my entire life. And so then he went to go look up the drug the next day and actually saw what it was being used for, or saw what it's typically used for, which is schizophrenia, and all of a sudden he's like, wait a second, why does my girlfriend have this? So, but be careful, because drugs can be used for multiple purposes, right? So you don't necessarily want to jump to conclusions there. However, sometimes this will be used as a sleep agent. As I mentioned, a lot of sleep agents tend to be controlled substances. So it was common back before, and again, depending on where you were at, for like mid-level practitioners and nurse practitioners, PAs, to write for these sort of drugs because they could do it without having DEA license and all of that. So you probably see this done less commonly, especially here now that you guys will be able to write for controlled substances. But just be aware that it could be, if you ever see like people taking low dose Seroquel at nighttime QHS dosing, that's typically what it's being used for there. Okay. A lot of these also have a lot of significant anticholinergic activity, so especially clozapine and olanzapine is known for this. A lot of dry mouth, a lot of constipation seen with that. So again, we know that mnemonic there. And then potentially seizures, and this is more seen at overdose, right? So clozapine and olanzapine tend to have the highest risk with that as well, right? So again, overall, it sounds like clozapine and olanzapine probably not the best out of the group here. Most of the side effects you're going to be seeing more pronounced with those agents. But sometimes if they fail everything else, those are the ones you have to finally land on.